So here the task says that you are FY2 working in GP and the patient has come for the checkup. The results of the checkup all are normal. The test results are normal except the cholesterol was a bit higher. I mean, the cholesterol was high here in this case, and the Q risk of this patient was 18%. Talk to the patient, and sorry, statin can be prescribed to the patient. Talk to the patient and disclose the test results and address her concern. By the way, this girl is not only for the test results. She's coming because she's worried about stroke. Can anyone what to do here? Can anyone tell me what to do here or how to approach this case? Like any other counseling station? Can anyone? Yeah, tell me. Tell me.
Once you enter the session, you will greet the patient with a smile or whatever. Then ask the name and then ask why she had this result before.
Yeah.
Whatever she will say, then you'll ask her how's the present condition at the moment. Is she experiencing any symptoms? Like that. And then we will move on with the past medical history and all the lifestyle history and some social history also. Then maybe she will have a bit, I would say, misfigured lifestyle. And we will examine her and then some initial investigation. Then we might maybe find that she's having high cholesterol. Then we need to advise her and talk to her about.
What is cholesterol, Dr. Massey?
Cholesterol is a fatty tissue, I would say, in the blood.
The bad fat in our blood.
Yeah, bad fat.
Okay, but not all of it is bad. Not all of it is bad. Dr. Elvira, she is not a girl. She's a lady. She's around maybe 40 something years old or 50 years old. Okay, so Dr. Massey, let me point out some few things. In the beginning, she told you that she has come here because she's worried about stroke, right? Why don't you ask her?
We will assess the stroke symptoms also.
Exactly. That's what I was waiting for you. Most of the people forget about that. Though you need in the beginning to ask about stroke symptoms, actually. Dr. Massey, I told you before, when someone is having some concern, at least try to assess this concern by asking 1 or 2 questions about it.
Yeah, I completely forgot about this stroke, by the way.
Yeah. By the way, most of the people do not know that she's worried about stroke. They just know that she's coming here for statin and cholesterol. No, she's worried about stroke as well. So you need to ask some few symptoms from the stroke. Number 1. Number 2, the problem is that here she will push you toward disclosure. When someone pushes you toward disclosure, Dr. Massey, what you can do?
We can first say that, okay, I'm going to discuss it with you, but would it be all right if I can
Doctor, I need to know right now, please. Doctor.
Sorry?
I need to know right now, please, Doctor. Tell me.
Okay, then we can talk about the result. That,
yes. The cholesterol was high, right? What is the cholesterol, Doctor?
Sorry?
What's cholesterol? What's cholesterol, Doctor?
Cholesterol, like it's fatty tissue in our body, and some are good cholesterol.
Again, you repeat the same. This shows that you are not concentrating, Nazir. I asked you before what's cholesterol, and you said the same thing. And the cholesterol simply is not a fatty tissue. It is a fat in the blood. You know, cholesterol is not tissue. Cholesterol is substance, okay? These things may sound ridiculous, but actually they are true. I mean, as a doctor, you are supposed to know about these things from the first year of medical school. Okay?
Okay.
So, what's cholesterol, doctor?
It's fat in our body, and some are good and some are bad.
Yeah, okay, it's a bad fat in our body. However, it's essential for the body function. However, sometimes when it increases the limit, when it increases the normal value, now it can cause some problem. So, for that, you told me that you are worried about stroke. So let me ask you a few questions which can put me in a better position to address all your concerns. Now you will ask her, number 1, past medical history. You will ask her about, do you have any medical condition? She usually is not having medical condition. Sometimes she can be having hypertension. Okay, you will elaborate it. Similar to stroke risk assessment station, exactly. Do you take any other medications or do you take any medications? Any family history of any medical problem? She would tell you, yes, doctor, my mother is having a stroke and that's why I'm worried about it. Oh, and I'm sorry for that. And how is she managed? And how has this affected her life? Now ask about the lifestyle as well. Smoking, diet, alcohol, physical activity, and stress. You can ask about her periods as well, if you wish. But the very important thing is that when you are disclosing, do not forget first to examine her, if possible, do neurological examination, and measure the blood pressure. Now, move to the task tells you that all the investigations have been done. So now you have to move to the management. Disclose to her that I told you that the cholesterol is high, and from my assessment, it seems to me that you are unfortunately at risk of developing stroke. Do you have any idea why? She would tell you why, doctor. You would tell her at this point, this because of 1, 2, 3, 4, which you picked from the history. So what can I do, doctor? There are some things that you can do and some other things that we can do for you. Again, like any counseling station. What would you like me to start with? Now she will tell you, doctor, tell me what you can do for me. You will tell her about the lifestyle advices. You will tell her about the medications, for example, the follow-up and the medications for the cholesterol. I told you that we measured your cholesterol and it was a bit higher. For that, we need to give you the medication, which will reduce the fat, the cholesterol in your blood. So your mission as a doctor here is to give her statin and follow up her blood pressure and blood sugar and her kidney and liver function test as well. She will ask you, doctor, what's a statin? You told her that it is a medication which reduces the bad fat in your blood. Doctor, does it have any side effects? Usually it's a safe drug, however, like any other drugs, it can have some side effects. For that, I'm going to have a look at my book. Excuse me for a moment. Now we are going to have a look at the book, the BNF. You will see that the side effects of the statin can be liver problem. It can be sometimes can be some headache, some tummy upset, but more importantly, if she develops any muscle cramps, come back to us. Muscle cramps are the warning signs here. Okay, doctor, for how long should I take it? Usually we recommend our patients to take it for lifelong. Okay, is it safe drug, doctor? Yes, it's safe. Now, what are the things that you can do as a patient? You will give her advice regarding the lifestyle, the physical activity, the diet, and the smoking, and the alcohol. Very similar to stroke risk assessment. I forgot one thing. What did I forget, Dr. Islam? I forgot one thing, Dr. Islam. I hope you were able to spot it.
Dr. Ahmed,
Yeah?
you forgot one thing in the management?
No. In the history. In data gathering, to be particular. Dr. Maisha, this is the first thing I asked about. Yeah, Dr. Muniba, bravo. You were the only one concentrating today. So the BMI is high, and also I forgot to disclose the Q risk to her. So when she asks you why, doctor, I'm at risk. Okay, Dr. Z. So when she asks you why I am at high risk, she would tell her that the result of the cholesterol, this is number one, and number two as well, the Q risk was high and the BMI was high. So three findings for her: high cholesterol, high Q risk, and high BMI. You will disclose each one of them, and she would tell you what you can do. You would tell her that there are some things that we can do and some other things that we can do. What would you like me to start with? So you will start your disclosure or you start your management by saying about the high cholesterol and high BMI and high Q risk. Okay. Family history. I asked about family history, Dr. Nigar. Family history is very important. Actually, that's why she's worried here. Fast in the management. The warning signs, yes, the warning signs you mean, Dr. Zaid. The warning signs that you are going to give her if you develop any facial weakness, any slurred speech, any arm weakness or problem, please come back to us. Okay, has anyone got any question? This is typically similar to the stroke risk assessment, apart from this is centered around the high cholesterol and statin.
Hello, Dr. Ahmed.
Yeah?
I have a question. Like, I got disconnected for a
Excuse
moment,
me?
so I couldn't like listen to some.
Excuse
I
me?
got disconnected for some moment.
Oh, yes, okay, tell me.
You can't hear me?
Yeah.
Oh, so we were in the past medical history that you were taking past medical history, and then I got disconnected, and then I heard from the statin. So can you please repeat for me?
Okay. So, in the past medical history, you simply ask about the medical conditions and you'll ask about the family history. Those are the most important things. I mean, those are the things to focus on. Medical conditions like any high blood pressure, any high blood sugar, any previous strokes, any mini strokes in the past. Do you take any medications? And then ask about the family history and allergy of as well. Do you have any allergy because you are going to prescribe to him statin? So do you have any allergy? After that, do not forget to ask about the family history because this is why she is worried about stroke. Then now ask about the lifestyle in details because lifestyle is a core to any counseling station as we agreed before. And then after the lifestyle, please examine her, especially neurological examination, and move to the disclosure. You are at high risk of developing stroke. Why, doctor? Because of some reasons. Number one, the cholesterol, which I told you about. Number two, the high Q risk and high BMI. Okay, so there are some things that we can do and some other things that you can do yourself. What would you like me to start with? Of course, you will tell her this management after explaining to her what is the Q risk and what is the BMI. So what would you like me to start with? Now she will tell you, doctor, start with anything, doctor. So now you can speak about the statin first. We're going to prescribe the statin for you. Explain about the statin in terms of compliance. You should take it every day. Side effects, you're going to open the B and F. Warning signs, like for example, if she develops any muscle cramps, come back to us. Then the thing that she should do herself is lifestyle modification, like diet, alcohol, physical activity, and stress. Okay, so anyone has any question here so far? I think this station is quite similar, I told you, to the previous stroke stations. But the problem is that it's centered around the statin prescription. Okay, so let's speak about today's station. I consider this statin was one more of yesterday's station. But actually, it's quite similar to the past ones that we discussed, but we did not have time. Um, we don't have time to discuss it. Right now, we are going to discuss today's sessions in details. Let's start with it's a challenging patient with medication list. This station is very easy station. However, many people they either score very high in it or they fail it. Why do the people fail it? Because sometimes the simulator may not let you take history. so you will get only one in data gathering, so they may mess you up the whole station. So what happens in this station? You are FY2 working in surgery department. The lady, she is 65 years old lady. She has been presented with a fall for which she had a hip fracture, and she has had an operation 1 week ago. She was admitted to the hospital, and she is now ready to be discharged. She has been assisted by your surgeon specialist, by the consultant, and she has been assisted by physiotherapist and occupational therapist, and all the medical team are happy with her. So now the assessment, she is fit for assessment. But your task here is to explain to her the further medications or the medication list. Which medications? Well, there is another special note which says that the reason of the fall has been found out to be postural hypotension, or was found out to be due to hypotension, due to the change in her drugs. During the hospital stay as well, she had UTI, for which she has been receiving 2-amoxiclav 1.2 gram in the past 3 days. She was taking painkillers, including codeine, and she developed constipation secondary to it. The medication lists are: number 1, bisphosphonate. Why? Because actually you have done DEXA scan as well, and the DEXA scan showed osteoporosis. So definitely this lady had a fall due to the recent change in drugs or due to the blood pressure medication, and due to her osteoporosis, the fall has caused her a fracture. And the fracture here, I mean, she will manage the osteoporosis by giving bisphosphonate and calcium and vitamin D supplements. Okay? And after that, actually, you may need to speak about one of the side effects of the medication, the codeine, is constipation. So you will give her Laxido sachet. It's written in the task, Laxido sachet. What's Laxido sachet? It is a sachet, like you can stir it in a half glass of water and take it. So simply, this task is only about explaining medications. So let's see how it goes. Number 1, you will enter the cubicle. You'll find a very nice old lady. She is very cooperative and very talkative, by the way. You will start the station by asking her, I need to ask you a few questions. Sometimes she push you, no, I was asking many questions, but I just need now to know about the medication. So if this is the case, what you can do? She will keep insisting on you to move toward the medication list. What I suggest is that you are going to explain each medication and ask about the relevant history. For example, you'll explain to her Dramapel. She will show you the list of medications when you enter, and she will ask you to explain every one of them. Okay, Dramapel number 1, Dr. said, I knew that this question is coming. That's why I told you that she will show you the list of the medications. So she will show you the big list of the medications, and when you enter the cubicle, what happens? She will ask you, Doctor, explain them to me. Now we will start by the bisphosphonate. He will say that actually the reason one of the reason of your fracture that you had is found out to be that you are having thin bones. Do you know what is it? No, doctor. This actually is a condition in which the bones become more fragile due to loss of some minerals from it. And that's why you have been giving you this bisphosphonates. Would you like me to explain? So now at least you mentioned that the bisphosphonate is because of the osteoporosis. So now you're going to explain the bisphosphonate. It's written in the list that it should be taken MANE, M-A-N-E. Please mark this word, MANE. MANE means like every Sunday in the morning. Doctor, she will ask you, Doctor, what is this mean? You will say that it means every Sunday in the morning. How should I take it, Doctor? Now, this information you should know that it should be taken in the morning, half an hour before your breakfast, and sit upright after it. It should be taken with a glass of water. So with a glass of water, half an hour before breakfast, and sit upright after it. Why? because it can cause some tummy upset. Okay, what should I do, doctor, or what should I look for? You'll advise her to look for any jaw problems or any jaw pain. Why? Because this medication can cause some jaw troubles. So it's advisable if you are visiting a dentist to show them that you are taking bisphosphonates. Okay, these are regarding the bisphosphonates. What else we can speak about here?
Patient doesn't ask for side effects, should we mention them or should we keep them for later on?
Excuse me? I didn't get it.
No, if she doesn't ask about the side effects, should we still tell them or should we just move on to the next part?
You must tell them. As a safe doctor, you must.
Okay. Thank you.
Okay. So this is the bisphosphonate. Number 2, let's speak about one other medication, the co-amoxiclav. In the co-amoxiclav, you are supposed to tell her that she should take the co-amoxiclav for 3 more days. Doctor, but I have been taking it, doctor, since like maybe 2 days. You will tell her that this medication is for urinary tract infection and its course is for 5 days. Now you should take the history of the UTI. For example, how is your urine right now? Do you have any burning sensation in the urine? What about any smelly or cloudy urine? Do you have any fever? No. So explain the medication and pick the relevant history. If you are explaining the co-amoxiclav, ask about UTI. If you are explaining the bisphosphonate, ask about the osteoporosis. And so on. You should take the antibiotic. It was written in the task, as far as I remember, it is written 3 times per day. So you should take it regularly as prescribed, even if your symptoms are gone. At least till the 3 days course or till the 5 days course is over. Okay, so this is regarding the antibiotic. Number 3, the codeine. Codeine itself is for the pain she was having after the surgery. It is written PRN, which means Prorinata. 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 Prorinata means as needed. So she will tell you, no, doctor, you guys are very complicated. Why don't you write as you did? You will tell her that simply these are the medical terms and we ourselves are used to them. They are even hard to us. Even you can joke with her. She's a very nice lady and fun one. So means pain required need, which means that she should take them whenever she feels pain, up to 4 times per day. The codeine and the paracetamol. So the codeine and the paracetamol are PRN. She can take them whenever she feels pain, up to 4 times per day. And it is written in the task as well. What are side effects of the codeine? It can cause some constipation. And that's why we are going to give you something else. We are going to give you something we call laxative sachets. What is it, doctor? It is a sachet, sort of syrup or sort of sachet. What for? It's for the constipation. You should take it whenever you feel constipated. Just empty the content in half glass of water, okay, and drink it or take it. So this is the laxative sachet, and you should take it maybe twice daily. What else? Doctor, you have made a mistake here. Which mistake? She would tell you, doctor, you know, you have, by the way, when you are speaking to her about the codeine and the paracetamol, you would ask her, and did you have any pain right now? What about any swelling in your legs? Are you able to walk on them? Are you able to bear weight? Because this is the relevant history of the fracture. You can ask before the drug, or you can ask after the drug explanation. But it's very important not to miss the history questions, because otherwise you will be getting no marks in data gathering. And this is why many people feel it. They surrender to the patient, and after that, they forget to ask history questions, which is very inappropriate because it's not only drug. You should take marks for data gathering. Okay, so now she will tell you, doctor, you made a mistake, by the way. Which mistake? Doctor, I know that I'm taking ramipril 2.5 milligram, and here you write 1.25 milligram. May I know why? Why this mistake? You will simply tell her that I'm glad that you realize this. But the thing is that we find that the reason for your fall was postural hypotension. Do you know about it? It is a condition in which your blood pressure drops down suddenly after changing your position from the lying to the sitting or standing, as it usually happens due to the blood pressure medication that you are taking. Oh, doctor, that's right. So, by the way, did you feel dizzy before the fall? She will tell you, yes, doctor. What about during the fall? Anything strange happened? Did you lose consciousness? No, doctor. After the fall, did you have any injury? Did you vomit? No, doctor. So now you took the history of the fall and you explained that the reason of the fall was postural hypotension. And that's why we needed to reduce the dose of your drug to the half. Doctor, but will my blood pressure be controlled and monitored? Don't worry, please. We are all here to help you with that. We're going to monitor you like every while to check that your blood pressure is well monitored and under control. So one last thing is calcium and vitamin D supplements. We are going to prescribe it to her. Why? To strengthen her bone, together with the bisphosphonate. If she asks you what is the reason or what is the use of bisphosphonate to strengthen the bone, how does it strengthen the bone? You know, guys, that it strengthens the bone by inhibiting the osteoclast and stimulating or giving the chance to the osteoblast. Or simply you can tell her it acts by inhibiting or slowing down the bone destruction process or the bone destructing cells and giving the chance for the bone building process. Calcium and vitamin D to strengthen the bone and add up the mist or the less minerals. So anyone has got any question? Give me 1 minute, guys.
Touch it. Guys, did we talk about the bisphosphonates already?
The game is not finished. What is the aim of the game?
Hello guys. Dr. Muniba has asked one question. Shall we mention that I want to check your vitals and food before you go just to make sure that you are fine now? Dr. Zid asked this is a good question. Did we give her bisphosphonate? So why second time around? Okay, so I mentioned it like I mentioned bisphosphonate twice, but I just told you that if she asks you about the bisphosphonate, why do you give the bisphosphonate? You would say that it is to strengthen the bone. How? By inhibiting the bone destruction process and giving the chance for the bone building process. Dr. Muniba, do not forget that in this station, you should not mention the vitals or the examinations. I mean, I don't say you should not. I mean, you need not. You need not to mention them because her fitness to discharge has been assessed by the surgeon and by all the medical team. Your only mission here is to only explain the medications to her, but still you need to gain some marks for data gathering. So this means that you'll find nothing in the examination. The only thing which you can find is in the history is to find the reason for the fall. Sometimes, by the way, the task here may not mention that you need to find out the reason. The task may not mention to you that the reason of the fall has been found to be postural hypotension. So in this case, you have to take good history of the fall. For example, ask her about the fall. For example, what happened before the fall? Did you notice anything strange? She will tell you, I felt dizzy. Now you elaborate the dizziness, and you'll find that from the history, she is taking ramipril. Ask her any recent change in the ramipril. She may tell you, yes, doctor, it has changed. So now, in some cases, you have to find out that the postural hypotension is the reason by yourself. So you need to pick it up from the history of the fall. Pick it up from the history of the fall. Okay. And that's why I stress on the fact that you must take history in this station. Just simple history. Do not take too much history. As well, if you have time, but I doubt that you will have time. If you have time, you can ask her about the home conditions. Like, for example, any loose carpets, any eye problem, any dim light, any wet floors, like this. However, guys, again, the reason of the fall has been found, her fitness and her home conditions have been decided by the occupational therapist. So no need to stress more on these things. I hope this was clear. So next station, smoking cessation. Smoking cessation is a very easy station, but unfortunately some people may underestimate this station. Why do people underestimate it? You simply, guys, in the smoking cessation clinics or smoking cessation clinic station, the people usually are having that concept that the patient is very easy and they're coming to talk about the smoking cessation and everything is fine. Actually, the both patients, COPD patient and the angioplasty, are stable patients. One patient is coming before the angioplasty. This one is coming to talk to you before the angioplasty because you need to find the best possible how to reach the best possible outcome from the angioplasty. For example, if you do the angioplasty today and they smoke tomorrow, so the angioplasty will not be successful. Okay. Okay. So in this case, simply the task says that you are FY2 working in smoking cessation or respiratory department. Okay. The patient is, for example, 50-something years old male patient. Okay. He's coming for the respiratory or for the COPD review. COPD review, which means that you still have to ask about COPD. In this case, you have to talk to the patient and assess the patient condition or assess the control of COPD. So here you still have to refer him to speak to smoking cessation clinic if he is smoking heavily. Okay. So here in this case, simply you have to start your station by asking the patient, how can I help you? Doctor, I'm here for the COPD review. Well, that's great. You did the right thing by coming here. Now you'll elaborate the COPD. Like, since when has it been diagnosed and how is it managed? He will tell you definitely blue inhaler and brown inhaler. And please be specific in your questions because you need to ask him how often you use the blue inhaler and what about the brown inhaler? Do you use it regularly as prescribed or not? He would definitely tell you that he uses the blue inhaler more frequently these days. Okay, so this means that this is one reason the COPD is not well controlled because he is using the blue inhaler more than he should do. Okay, do you have any symptoms of COPD? Like what, doctor? Do you have any cough? He will tell you, yes, doctor, I'm coughing these days. Elaborate the cough and if it is with phlegm or not. and if there's any blood or not. Actually, the cough here is productive cough and with blood. So what does this mean? This means that this patient is definitely going into lung cancer. Do you have any complications of the COPD? For example, do you notice any weight loss? No. What about any shortness of breath from time to time? No. Okay. So this is the elaboration of COPD. Now ask past medical history. Okay, like how was your health recently? Any fever or flu-like illness? Now ask about the medical conditions. Apart from COPD, do you have any other medical condition? Do you take any other medication? Allergy? Family history, very important. And family history of lung cancer as well is important here to ask. Now move to the lifestyle. Do you smoke? Usually this patient smokes at least 20 cigarettes per day since 20 years or 15 years. Heavy smoker. Okay. Now ask the patient about the physical activity and the alcohol and diet. Examine the patient because this is a checkup review. Examine the patient including chest examination, and you can hear that the chest, there can be wheeze in the chest, or can be some crevitations or some reduced air entry, whatever, but they can show you some respiratory impairment. Move to the investigations. In the investigations you should do here in this station, chest x-ray and spirometry. What is spirometry? You know, PFR is something like it, but for the COPD. So chest x-ray and spirometry. The examiner will give you nothing. You will stay silent. Now move to the patient and tell him that your COPD is not well controlled. Do you have any idea why? Why, doctor? Because number one, from the history, you are coughing and using the blue inhaler more than you should do. Number two, from the examinations, your chest is showing, and give him the signs of the examination. Okay? So, doctor, and thou ask him, do you know why it is not, do you know what is this, or why is this, or why you are having these symptoms? He will tell you, no, doctor, actually it is because of smoking. Oh, doctor, I don't believe this. May I know why you don't? Doctor, because I know that doctor, I love smoking, seriously. I can't stop smoking. I don't believe it's the case to me. So this guy actually is not aware about the problem. So you will ask him the few questions, or you will tell him, I know that it can be frustrating and it can be disappointing sometimes to talk to you about this thing, but do you know what smoking or what if you quit smoking, what will happen? If you quit, now explain about the benefits. Or why you should quit smoking, because actually quitting smoking will improve your health and improve your immunity and prevent the shortness of breath from coming all the time. Still reluctant? Now offer the complications. Do you know what will happen if you do not stop smoking? Now you can speak about the smoking can worsen his lung problem as well, and can cause some other troubles, including some heart attack or some strokes and some other problems in different parts of the body. So, doctor, what can I do then? We definitely can help you. We have something called smoking cessation clinic, which can help you with some variety of options. Some of them are medical and some are non-medical. What would you like me to start with? Now he will tell you start with anything. So now explain the benefits. Number two, the complications. Number three, smoking cessation clinic offer solution. One of the complications as well that I forgot to mention is that you can tell him that one of the complications of uncontrolled COPD is lung cancer. And I'm sure you do not want this to happen to you. Besides some other complications like heart problem and stroke and some other blood problems as well. Now we will offer smoking cessation clinic, non-medical and medical. What is the non-medical? Trained advisor, group therapy, online access. You know, remember the alcohol? It's definitely like the alcohol. What the medical therapy? The medical therapy is nicotine replacement therapy. Nicotine replacement therapy in the form of gums or in the form of patches. They reduce the withdrawal symptoms, like stress, like tummy pain, like agitation, like whatever. What else? And the other thing is e-cigarettes, the electronic cigarettes. They are not as good as a nicotine replacement therapy. However, they still are more safe than the normal cigarettes. Number 3, varenicline. Varenicline blocks the reward pathway in the brain from smoking, which means that prevents your longing for smoking or your addiction to smoking. Those are the medical options and the non-medical options. Again, the medical options, nicotine replacement therapy or patches, and e-cigarettes and varenicline. Doctor, but I don't want to stop smoking. So this patient is still reluctant. Now you have to fear him more. You still need him. One of the complications of the COPD as well is that you may need long-term oxygen therapy, which means that you should receive oxygen for lifelong. Having a cylinder around you all the time, I'm sure will be disappointing to you, and we don't want this to happen to you. So you will tell him that he will need to be restricted to oxygen cylinder all the time. Now he will be scared. Okay, so this is a COPD station. Has anyone got any question regarding this station? Any questions so far? Because the next station is quite similar to it, with a little bit of twist. Next station is the same station but angioplasty, and it is before the angioplasty. The special note here says that the patient is not willing to stop smoking. So you are going to have a tough time inside the cubicle because the patient does not want to stop smoking or is not willing to stop smoking. So here you will enter to the patient, you will say, how can I help you? She will tell you, doctor, I was set to have a procedure, and I was told that you are going to talk to me about it. Now ask her which procedure. She will tell you the angioplasty. How much do you know about it? And then you can explain it to her as we insert a tube, a narrow mesh wire tube, okay, into the blood vessel supplying your heart to widen any narrow in it. So mesh tube or mesh wire tube in the blood vessel supplying your heart to widen it. Okay, doctor. May you know why are you set for this procedure? She will tell you, doctor, because I was diagnosed with angina. Now, ask her some few things like, for example, which symptoms did you have? She will tell you, doctor, I used to have chest pain. She will tell you a full story about angina. And have you tried anything to make them better? These symptoms, she will tell you, doctor, I took medications, but they did not help me, and that's why I came to the clinic. Now, ask from her some past medical history, like, have you had any similar heart episode or heart problems in the past? How was your recent health? Number 2, any medical condition? She is having hypertension. No, she is not having hypertension. She is absolutely free. This lady is absolutely free. She's absolutely fine. And do you take any medications? Any allergy? Any family history of heart problems? Now move to the lifestyle. But one important point here is do not bring the smoking in the lifestyle right now. Why? Because the task tells you that the patient is not willing to stop smoking. So now you know that she is not willing to stop smoking, so please do not speak about smoking. Sometimes she can start the station by telling you, doctor, I've been told that you're going to talk to me about the procedure. But if you're going to talk to me about smoking, I'm going to leave right now. So please don't talk about smoking at all. So she is angry and she does not want you to talk about smoking. So please respect her wish in the beginning. Just, like, Try to be smooth in the beginning, and after that you can move to the concern in a while. I'll tell you how. What you should do right now, simple. Move to the lifestyle as I told you. Ask about diet, physical activity, alcohol, and stress. Everything is negative. Sometimes she's having stress as well. Do some examinations. Examinations are normal. You can also order some investigations, including ECG. It's normal here. So you will tell her that thank you for being with me. Okay, so now your mission was to find out the best possible thing that could bring heart attack to her back again. I mean the thing which can make the angioplasty less likely to succeed. So you will tell her thank you. Do you have any idea why did you get these heart problems before? She will tell you, doctor, I don't know, doctor. Well, now you will tell her that we measured everything. For example, please do not forget to mention about the BMI as well in the examination, in the general physical examination. You will tell her that we checked everything, like we checked your like your BMI, it was fine, and you don't have any medical condition. Actually, also you are physically active, you are following healthy, balanced diet, and you drink alcohol in moderation. So do you have any idea what could be the reason? She will tell you, doctor, maybe it's because of stress. Well, actually, you tell her that you're right, stress can be a reason, but it's not the main reason for having these heart problems all the time. So what do you think it could be? Oh, Dr. Amy is smoking. What do you think? She will tell you, doctor, I don't think so. May I know why? Doctor, because you know, my father used to smoke for 10 years and he did not have any heart problems. Now you will tell her that your father was a lucky one, because it's not the case for all the smokers. Doctor, but all doctors smoke. You can tell her as well that not all the doctors, but not what the doctors do is the right thing. So it's not supposed to be the right thing all the time. So ask her, have you ever thought of cutting down? She will tell you, yes, doctor, I thought once before. And why didn't you? She will tell you, doctor, because I started having some stress. And may I know why you think it's because of smoking or quitting smoking? Doctor, because smoking enables me to handle the stress. Now you'll explain to her that this is wrong conception. Why? Because actually it's always, actually the stress due to the withdrawal symptoms is due to the withdrawal from smoking. I mean, the stress actually is due to the withdrawal from smoking and not because she is not smoking at all. I mean, for example, it can be like normal life stress and she doesn't have any ability to cope with the stress. And now when she stopped smoking, it even worsens the condition. So this is wrong conception. People always confuse the normal stress and their inability to cope with the stress with the stress which is released or which is due to the quitting the smoking. But doctor, I cannot stop it. May I know why? Doctor, I don't know, doctor. We can help you with that. I can see that you're quite concerned about that, but we can help you with that. How, doctor? Now you can refer here to smoking cessation clinic as the previous station exactly. So here, how to convince her, you asked about all the lifestyle questions. You found all of them negative. You came to the management and you disclosed to her that we found this and this and that, and all of them were negative. So do you have any idea what could be the reason? She would be stressed. Okay, I'm glad that you know about that, but actually the stress is not the main reason behind that. So what you can think? She will tell you smoking? Oh, may I know what you think? She will tell you, no, doctor, I don't think so. May I know why? So now we will start from here. And you can ask her, like, for example, how much do you smoke? Since when have you been smoking? Have you ever thought of cutting down? She will tell you, yes, doctor, I tried, but I didn't manage. So this is another reason for her to be not willing to stop smoking. So basically, this lady does not want to stop smoking because of the withdrawal symptoms of smoking. So you can reassure her that we can provide you with or can send you to smoking cessation clinic, and they can provide you with variety of options, medical and non-medical options. And you speak about everything of them. One note is that when you are speaking about the non-medical options, you can tell her they're having variety or like many trained smoking advisors. So you're going to have talks with them together with other groups of people who were smoker and quit smoking before, so you can learn from their experiences. I'm sure this will be fine and this will be enjoyable, right? Try to encourage her all the time and try to like this is marketing. This is sort of marketing to her. If you are doing this, you are convincing her more. Your mission in this station is not to be like too robotic. Do not be too robotic in this station because the lady is very stubborn. Anyone has got any question regarding the smoking cessation stations?
So, Dr. Ahmed, this scenario is for the convincing the patient to quit smoking, right?
Excuse me? This scenario is what?
This is station for convincing the patient to quit smoking.
Yeah.
So that's a whole subject. Okay.
Yeah. This station is to convince her to quit smoking. Why? You know why? Because actually, if you do not convince her, or I mean, if you do not manage to convince her to stop smoking, you are zero in management.
Zero management.
Yeah, in this particular station. This is the main thing in this station. If you fail to convince her, unlike the warfarin is the guy himself, he does not want to take warfarin because of some other reasons. But in this case, you are supposed to convince her to stop smoking.
So it's not about So it's not about angioplasty and discussion on angioplasty, right?
No, you can discuss that, but okay, tell me, what can you discuss in angioplasty? You just explain the procedure to her and how to reach the best possible outcome to her. It's not about the pre-operative and the operative and post-operative. It's not about this at all. No.
Not about this one.
No. Why horrible, Dr. Muniba? Why? Tell me.
Because the patient, most of the time, she actually never can get convinced on stopping the smoking. I mean, she's like, whatever you say, I don't care.
Yeah. Okay, at this point, you can tell her that I can see that you are quite bothered by something, or you are bothered by something. Is there anything bothering you? She will tell you, maybe your words are bothering me. I am sorry if I gave you this impression.
Exactly.
I'm sorry if I give you this impression. I'm just talking about your health. Would you like me to tell you why I'm telling you this? Why, doctor? Because actually, one of the complications of smoking in your condition is that you may develop heart failure. At this point, actually, you would end up taking some oxygen and some other medications as well all the time. And you can have heart attack at any other time. And if this ever happens, this can cost you your life, which we never want. So this is the thing. You have to be convincing here.
Yeah, you're right.
Hello.
Yeah?
Okay. When I enter this cubicle, at that time, if the patient...
Your voice, Dr. Man, your voice.
Okay. If I enter the
cubicle... Your voice is far, very far.
Okay. Hello. Is it clear now?
Yeah, it's clear.
Sorry for the interruption. If I enter the cubicle and if the patient says me that I don't like to talk about smoking. If you want to talk about smoking, then I will just leave the session or I will leave the cubicle. If the patient told me initially, so just after that, how should I approach? Should I tell you, okay, I am not going to tell about smoking now, or should I tell something else?
Okay, simply tell her, okay, that's fine. I'm here to talk to you about the procedure in general. Please, I'm just going to ask you a few questions about some other things.
Okay.
So now I'm going to ask you a few questions regarding the procedure and some other things. And in the end, if she ever tells you, doctor, You told me that you're not going to mention smoking. That's why, guys, that's why I told you in the beginning that you are not the one supposed to tell her. Everyone mute themselves, please. I told you that in the beginning, in the management, you are not supposed to you yourself say about smoking. No, you will let her utter the word smoking, because you keep asking her, do you have any idea what could be the reason? What do you think of? Now she will tell you smoking. Yeah, sometimes she can pretend that she's leaving the room. Don't ask about smoking in the lifestyle questions, Dr. Maria. She may really be rude to you, and you don't want anyone to be rude to you. No, Dr. Maria, you do not ask about smoking at all. You ask her, do you think what could be the reason? I mean, after disclosing that nothing is positive at all. So what could be the reason you think? She would tell you, doctor, I don't know. You tell her, can you think of anything? Doctor, you mean smoking? Now, what you think? Again, you will ask her, what you think? She will tell you, doctor, I don't think so. May I know why? Now the conversation starts. Now, by your intelligence, by your way, you brought her, or you let her open up to you.
Okay. Yes. This is for a better approach. Thank you.
Okay. Wait. Sorry. Hello. Wait, let me check the questions. These patients, alcohol and smoking, I find not easily to persuade. I can't. Okay. How was the flight? Oh, yes, Dr. Zaid. Actually, yes, lean forward and speak slowly with passion. That's what I used to do, actually, all the time. And it brings very good results. To lean forward and to show the patient that you are really caring. This is what you should do all the time. Okay, let's move to some. Has anyone got any further questions in this station? Okay, let's move to the next stations. Next stations is the Acne Station, one of the most boring. I mean, one of the most, like, how can I say, most strange stations in PLAB. You just pray that you do not get this station your day. Why? I mean, it's easy, but it's not clear so far. I mean, it's not clear what could pass through and what could fail use station. No one knows still so far, because you know some people have like practiced it the way it's found in the video. There is a video which is found on YouTube. I can send it to you right now. Wait. Yeah, it is demanding acne patient for the CSA. I'm sharing it to the WhatsApp group right now. Please try to have a look at it after we are done with this session. Yeah, we will discuss it, but in the end, in the pediatric section, the pediatrics. Actually, I have got the concern of the patients so far from the people who took the exam. So I'm trying to gather data about this station and one other station as well, which is, wait, let me check my papers, because I have made the list of the stations which should be missed, or we are missing. Hold on. The cold sores, the herpes labialis, the station, and the leukemia are still not clear so far. So those two stations and the post-herpetic neuralgia as well. But here, the post-herpetic neuralgia, we all know how to manage it. Those are the two stations that are missed. So I sent you guys the CSA video for the acne medication. Please watch this video after we are done with this station. Why? Because this station is quite challenging. This station, I mean, you have everything around you in this station. You have the BNF paper. I mean, even the GMC will bring you separate paper from the BNF. They will bring you only the isotretinoin paper on the table, which is the acne medication. We are talking about the acne medication station, Dr. Massey. So now, for the acne station, here she is a girl. She is like maybe 22 years old girl. She is here because she is having acne and she wants to discuss her problem with you. She is asking for isotretinoin. Isotretinoin is the acne medication. Now, actually, in this station, you must check the BNF. If you not check the BNF, you will not pass it. I'm telling you honestly. If you do not check the BNF, you are not going to pass it. So now, you will enter. Dr. Zaid, actually, I recommend to watch this only video for the acne, and some videos, they are just, they are just selective videos, like maybe the polymyalgia rheumatica and some other videos like Breaking Bad News. Some very few videos, but I mean, do not follow them with the heart because they are containing long things which you will never have time to cover. I mean, just if you have no idea about how the doctors in UK speak and how to approach the patient, it's fine. It's fine if you just have a look at them. So what you can do right now, number one, you will enter, you will greet the patient, ask her, how can I help you? Doctor, I want the acne plus, or I want the acne medication, is this medication? She will show you isotretinoin. No, so ask her, may I know why you want it? Doctor, I want it because I want my acne to be gone, or I want my this. She will not tell you acne. I want the spots in my face to be gone. Yeah, separate paper in which the isotretinoin is, I told you, separate paper from the BNF. Actually, this is the paper which is a copy of the BNF. They just separated it from the BNF and they brought it to you on the table. So that you'll have, and by the way, when you open this paper, you'll find like maybe 100 side effects written. So you'll be lost in the middle. But I tell you what to do right now. So you will enter. She wants this medication to be taken, and she why? Because she wants these black spots or these spots, sorry, to be gone. So now you will ask her some few questions, like for example, since when have you been having these spots, and do you have them anywhere else? Have they changed? like in color or in shape? Do you scratch them? Do they bleed? Do they ulcerate? Like any skin problem, as I told you. Can you think of anything which makes them worse? She will tell you, yes, doctor, sometimes when I'm eating chocolate, sometimes when I'm exposed to sunlight, sometimes when I'm stressed and having exams. Okay, she can give you any trigger. Okay, now you can ask her as well some few questions like, can you think of anything which brought these thoughts to you? She will tell you, no, doctor, I don't know anything, doctor. For example, when someone is having such thought, they could have a change in their like face lotion or face wash or such thing. No, doctor, I have not changed everything like this, or I have not changed anything, doctor. I'm very particular about my look. I'm a drama student. So she's a drama student. She's an actress. And that's why she's very concerned and she wants the acne to be gone as soon as possible. Ask her some past medical history, like has this ever happened to you before? How was your note recently? You can ask her two questions in the medical condition. Like, here the acne, it's a close association with the PCO. So for example, did you notice any hair growth in any abnormal site or any abnormal place in your body? No. So this is PCO, right? Okay. Do you have any medical condition, like any diabetes? No. Any family history of any problem? Any family history of acne? She can tell you yes. Lifestyle, very important. Diet. She is very particular about her diet. She eats healthy, balanced diet. Why do you think? Because she's an actress. What about physical activity? She is quite physically active. Smoking, she may be a smoker, like but a slight smoker. Alcohol, very moderate, like social drinker or very light. So now ask her about the period as well. She's female. Very important here to ask her about the period and the pregnancy. Please write this in your notes to ask about these things, periods and the pregnancy. Why? Because they are essential when you are prescribing any anti-acne medication. If she is having or if she is liable to be pregnant or supposed to become pregnant soon, definitely she cannot receive the acne, either the gel or the pill. So, how is your menstrual period? Is it regular or not? When was the last menstrual period? By any chance, could you be pregnant? No. So again, number one, you elaborate the spots. Number two, you ask about any recent change in your face lotions. Number three, take some past medical history. And number four, ask about lifestyle and periods. Now examine the patient. How to examine the patient? You will ask the patient, I need to have a look at the spots on your face. The examiner will show you a picture of spots. Actually, she's having mild to moderate acne. Sometimes she can be having moderate acne, and some other times she can be having mild acne. Okay. In these cases, actually, you are not supposed to give pills at all. So please try to watch the photo or try to have a look at the photo of the mild acne and the moderate acne. I'm going to send it to you actually when I'm taking a break after a while. But simply, what you can do here, you can tell her that thank you for bearing with me and answering my question. By the way, she will keep insisting on you that she needs a pill. She needs a pill. But okay, that's fine. Just let me finish my assessment, and if everything is fine, I can prescribe the pills for you. So what you can do here in this case, you will tell her, actually, it seems to me that, we can give you, sorry, you will tell her, actually, we can give you some medication for the acne. Okay, we are having two medications. One is the pill, and one is in the gel form. Doctor, I want the pill. Well, actually, in your case, I'm afraid that you are entitled to receive the gel one, not the pill. May I know why, doctor? Because your condition, number one, your condition is mild form. Number two, the acne pill are having many side effects. Some of them are serious even. Which side effects, doctor? Now you can excuse a moment from here and have a look at the paper by your side. One important question I forgot to ask is the history. When you are taking the history, which question I forgot, Dr. Zaid?
So how does this impact your life?
Perfect.
Yeah.
This is the most important question in the history, by the way, because that's why she's here in the GP clinic. Because these spots made her shy to appear in the show. And that's why she needs the acne pills so that it will help her. No, not the BMI. No, Dr. Albero, not the BMI here. This time you're mistaken. By the way, she's very slim. I mean, she's very slim girl, and she's very insisting. So here in this case, you will tell her that actually you can receive the gel, but doctor, why not the pill? Now excuse yourself and look at the BNF and find many side effects. We'll tell her that your condition, yes, she was. So actually your condition is mild, and number two as well is that it could be having some serious side effects or some side effects. Now we will say side effects from the BNF. The most important side effects are menstrual irregularity, and if she ever becomes pregnant, this can cause some abnormalities in the pregnancy. Like it can affect the baby as well. Moreover, it can cause some mood changes, it can cause some skin irritation, some eye problems, some liver problem as well. So please make sure that you look at the BNF and see the side effects from it. That's why they brought it to you as a separate paper. But doctor, I need to take it. May I know why? Because doctor, this will ease my spots very easily and very quickly. Actually, we have some other option as well. It can be very suitable to you. Which option? Now you can speak about the gel. Okay, doctor, tell me about the gel. You will tell her that this gel as well will be taken, and it could be having some side effects, but it is less than the pill itself. Which side effect is a local side effect, like skin irritation, sometimes problem to the sunlight, okay? Sometimes, and very rare times, some eye problem. But two important warning signs here to be given in the pill or in the gel. That you will advise her that by any chance, if you are becoming pregnant, come to us. We may need to stop it to you. This is number one. Number two, it's very important while taking this medication is to take 2 methods of contraception. Very important to take at least 1 method of contraception with the gel, but very important 2 methods of contraception with the pill. That's why it has many cautions, and that's why we do not recommend it to our patient in the oral form. So with the gel, at least 1 method, and better 2 methods. And with the pill, it's must 2 methods of contraception. Then, doctor, but I need the pills. If she insists on taking the pills at this point, you tell her that actually we can refer you to specialist. The specialist will run many tests to you, and if he finds you fit enough to receive them, he can prescribe them to you. So in this case, by the way, you are FY2, you cannot prescribe the pill. You should refer her to specialist in the end. So your mission is to convince her that the pills are not suitable. Number one, her condition is mild. Number two, they are having many side effects. Number three, you are not the one who will prescribe them. You can give her the gel only. How long does the gel take? The gel takes at least 6 months till the acne starts improving. And it will resume, or the improvement will continue even after that. So this is the thing. This station is quite, it's easy station. But the problem is that the attitude of the girl herself. So you need to know that you should not ever prescribe the pills to her under any condition. not refer. In the end, if she is not satisfied, we can arrange for you, or we can refer you to specialist, the skin specialist, and they definitely can talk to you and assist you further to see if you are able to receive the pulse or not after doing some further tests and scans for you. This is in the end of the station. You can prescribe the cream. Yes, the isotretinoin cream can be prescribed by you. You can prescribe it. But what you can't prescribe is the pill. Anyone else has got some other question here? Again, any question in this station? I know that's like it's boring, it's very boring. You just pray that you didn't get it. Why? Because of the behavior only. Very boring or very annoying girl. Okay, so next station is the colonoscopy, the IBS guy. This station came first in January. It's one of the easiest stations. I mean, it's one of the stations that Dr. Islam is asking if she is okay with the cream. Yeah, do not mention, by the way, she will not be okay with the cream. She needs a pill. And that's why you explain the cream and explain everything about it and tell her why we prefer it and why we prefer it over the pill. In the end, if she is still insisting, you can tell her that we can refer you to skin specialist to discuss this with you about the pill. Okay, next station is the IBS, the Irritable Bowel Syndrome. I think all of us know about the Irritable Bowel Syndrome, not just pure knowledge, no, it's like pure experience, not only knowledge. So, in this station, the guy is 50 something years old, like 55 years old, and he is coming for the colonoscopy. Sorry, he is coming for his checkup. And the task says that the guy is 55 years old, gentleman coming for the checkup or having some concern, having some tummy problem or having some bowel problem. Talk to the man and or talk to the patient and address his concern and also address the need for colonoscopy. The task tells you address the possibility or the need of colonoscopy. Okay. Now you enter the cubicle, you'll find a gentleman who's having some tummy upset. Not upset, he's having some bouts of diarrhea which come to him. Sometimes bouts of constipation, bouts of tummy pain. So you will elaborate it. You will find that this problem or this tummy pain together with this constipation started coming recently or started like increasing recently. Okay, so again, he's having this tummy pain or this constipation at least 30 years, and it's getting worse these days. Why? Because he's preparing for his PhD exam, his PLAB 2 exam, his anything. So he's preparing for the exam, and that's why these bouts started coming, or this episode started coming more frequently these days. If he's presented with tummy pain, ask about any change in bowel habits. If he's presented with diarrhea, ask about tummy pain and constipation. I mean, these three things must be asked together. What are the associating symptoms? Fever, weight loss, nausea, vomiting, right? You have to ask about these things. What are the other symptoms of the irritable bowel syndrome as well? You can also ask if he's having any headache, if he is having any loss of appetite. Okay, so the associating symptoms of the irritable bowel are headache, loss of appetite, maybe heartburn. Okay, what are the associating symptoms of the bowel problem? Are abdominal pain, constipation, diarrhea, loss of weight, nausea, vomiting, and fever. All the symptoms for gastroenteritis. Now take some past medical history. And by the way, what are your DDs here? Your DDs could be maybe UTI. Yes, if he's having prolonged diarrhea, you can ask about dehydration, Dr. Kashi. What are your DDs or your differentials here? He is having tummy pain. This could be UTI, for example. Could be GIT infection as well. Could be IBD, irritable bowel syndrome. Okay, so in this case, actually, you will ask some past medical history. Have you had any similar episodes in the past? You will tell you, yes, doctor. I had similar episodes in the past, and they were typically the same. Okay, so this guy is having these episodes in the past, and they are typically the same, which means that he could be either having diarrhea or constipation. He is having one of them. So this cannot be IBD because the IBD is alteration of diarrhea and constipation. But the irritable bowel syndrome is mainly one of them, either constipation or diarrhea. Now, ask about the general health. How was your health recently? Fine. Any medical condition? No. Any bowel problem? No. Drugs? Negative. Family history or bowel problem? No. Ask about the lifestyle. Do you smoke? Do you drink alcohol? What about your diet? What about physical activity? You know, the lifestyle questions are still important in this case because you know any bowel trouble or any prolonged bowel trouble can be related to the lifestyle sometimes. Sometimes due to the meal itself. Sometimes also can be due to the inactivity. So now ask about stress. Please mark that you need to ask about stress in this situation. Stress is the most important thing. He would tell you, you would ask him, do you have any stress? He would tell you, yes, doctor. I was preparing for my PhD and I finished 1 week ago. How are you coping with that? Doctor, it's fine, doctor, but it's getting so hectic. And he will start talking too much. What's your job? He will tell you anything. Maybe he's a teacher, maybe he's something. So now examine him, tummy examination, and please perirectal examination as well. Any tummy problem, it's better to examine the perirectal. Do some investigations, including routine blood and urine and stool. In any bowel problem, your initials should include stool. Doctor, what's wrong with me? Now you know that this guy is having definitely irritable bowel syndrome. Why? Tummy pain together with some diarrhea or constipation, according to what the patient gives you, which can be related to stress and comes in episodes each time he's having stress in the past. One important question as well, if I forgot to ask, you can ask him, for example, have you noticed that this comes after some certain type of food? He will tell you no, doctor. So now you rule out celiac disease. So again, your differentials could be cancer, could be celiac disease, could be IBD. You will tell him that you're having a condition we call irritable bowel syndrome. What is this? Some bowel alteration or some bowel upset. Okay, some episodes of tummy pain together with diarrhea or constipation in your case, for example, and they can be related to some other things as well. One of them is a stress. You told me that you are preparing for or you were preparing for the PhD. This could be one of the factors that led you to have this. So what I'm supposed to do right now, doctor? Right now, you're going to give him some lifestyle advice. Like what? Number 1, smoking. Number 2, alcohol. Try to be physically active. Diet. Maintain healthy balance. Please focus more on diet lifestyle here. Maintain healthy balanced diet. Avoid the food that could cause you such a problem, like the spicy food sometimes, like the heavy and the fatty food sometimes, like the tea, like the caffeine sometimes as well. Okay? Try to maintain healthy, balanced diet and includes fruits and vegetables in your diet as well. Try to not take any heavy meals before the bedtime, and try to spare like maybe 4 or 5 hours between your last meal and your bedtime. You know, the dietary life advice are exactly like the reflux. because the reflux is sometimes part of the irritable bowel syndrome. So definitely they are like it. Okay, what, doctor, aren't you going to give me anything? Well, actually, it depends sometimes. If he is having some tummy pain, we can give him some painkiller. And for the bouts of diarrhea, we can prescribe you some loperamide, antidiarrheal medication to be taken only in case you have any occasion or any travel or any trip. And for the constipation, it's advisable as well to stick to the fruits and vegetables. However, you can be prescribed some laxatives in case you are having any occasion as well. So it's only symptomatic for the tummy pain, for the constipation, and for the diarrhea. Doctor, aren't you going to do any tests for me? Now you will tell him that we can do further tests for you. Which test, doctor? Now you can tell him that we can do to you some scans, like including ultrasound and CT scan. If the results came back normal, we may consider referring you to specialist as well to perform one camera test for you. Why camera test, doctor? Well, this test to visualize the inside of your bowel to make sure that you don't have any other problem. But doctor, you told me I'm fine. Well, actually, you don't have any symptoms suggestive of anything. However, in your case, we need to confirm the reason. And that's why we are referring you to specialists to perform this camera test for you to make sure that everything else is fine. You know, guys, that the IBS usually is diagnosis of exclusion. So you need to rule out other medical causes. So you need to give him some lifestyle advice and refer him for colonoscopy. Why colonoscopy? To rule out other bowel problems, including serious conditions. They will ask you some questions regarding the colonoscopy. Will it be painful? Will numb the area and mild sleeping medication? Does it have any complications? Some pain, okay, some infection as well. Sometimes it can cause you some bloating. Like this, we will speak about the colonoscopy in details, and we will discuss the colonoscopy in details tomorrow in the other surgery stations as well. So this is the station so far. It is a very easy station. You have to know only one point from this station, is that IBS is treated by lifestyle measures. And number two is that you should do colonoscopy to this patient even if you are sure that it is IBS. Why? To exclude other medical problems. To exclude other medical problems. Okay?
Dr. Ahmed?
Yep.
Yes, just if the patient asks us why you want to do camera test, can we reply to them that according to the NICE guidelines, we recommend every patient above 50 to do screening test to rule out cancer?
Well, actually, why do you speak about NICE guidelines and you can speak about the patient concern himself? You can concern him, or you can advise him, or you can even convince him very easily by saying that we need also to rule out some other medical causes, like which can be associated to your condition. Very simple. I mean, in any station in PLAB 2, you can mention about the guidelines, but why the guidelines were put in the first place? The guidelines were put to exclude other causes.
Yeah, but you know, every patient above 50 in UK, they recommend them to do this endoscopy.
Why?
It's a part of national guidelines screening. For example, for breast screening and for bowel, it's called bowel screening.
And why?
Yeah. To rule out cancer of the bowel.
Yes, that's why I'm saying.
Yeah.
So you just bring it. It's very simple. Okay, you can say it definitely, but I'm just telling you that.
But your approach was right, because my answer is more senior doctor, not for junior doctors. Yeah. Okay.
It's just patient, just to be like a more patient-centered. That's it. Okay, let's speak about one last station for the counseling, after which I'm going to give you some few minutes break. The HIV station. HIV is coming in different scenarios these days. So the HIV stations are very easy, but the problem is that, you know, about the partner himself, about the guy himself. He's always having problems with the partner. Okay, so here, in this case, you know, in this case particularly, the patient is known to be having HIV. So here, half of your mission is done. He knows that he's having HIV. You just take him some history from him. By the way, the task say that you're FY2 in GP surgery. The patient is diagnosed with HIV, and he is here to discuss the management plan with you. Talk to the patient and address his concern. Still, you need to take some history, like 2 or 3 minutes history at least. Now ask the patient, may I know how can I help you? Doctor, I was diagnosed with HIV and I have some concerns. Now reassure him, I'm here to help you and support you. I'm sure you're having a tough time. Please don't worry, we are all here to help and support you and guide you through this. Okay, so tell me, which symptoms did you have? Like he can tell you anything, like maybe lumps or bumps, maybe loss of weight, maybe frequent, anything. Elaborate them and ask him about other symptoms of HIV. What are symptoms of HIV? Weight loss, tiredness or fatigue, frequent infections, some fever, low-grade fever, diarrhea, lumps or bumps. Many symptoms. Just ask about 2 or 3 of them. Past medical history. Do you have any medical problem? Apart from that, how was your health recently? Do you have any medical problem? Do you take any medications? Any family history of similar problem? Okay. Lifestyle questions, smoking. And please ask about sexual history here. The core here is the sexual history and the travel history. He definitely had unprotected sex, and I think also in Germany. They're always showing Germany as in such cases. Okay, so now, what if he does not want to open up? It's fine. I mean, you just reassure him, please don't worry, we are all here to help support you. And he'll tell you, Doctor, I had unprotected sex. And by the way, this guy particularly is very open. He was already diagnosed. So now you'll examine the lumps and bumps, move to the management. Thank you for letting me ask you these questions. Now tell me, please, what's your concern? Doctor, I'm concerned about how you are going to manage me. Okay, for the management of the HIV, please try to focus on it. I'm summarizing it for you in an easy way. I divide the management of the HIV into number 1, medications, number 2, follow-up, number 3, support, number 4, partner notification. Again, number 1, medication, number 2, follow-up, number 3, support, number 4, partner notification. And when it comes to the partner notification, he's already having some other concern we know right now. Okay, so now number 1, regarding the treatment, we're going to, he was already, I mean, he has undergone some CD4 count and ELISA as well. So he had done the HIV test. So we will start the treatment. I will discuss with my senior and we can start your treatment, or we can even refer you to HIV specialists, because there are HIV or gum clinics which can start them on the medications. Sometimes you are in GP surgery in this task, and some other times you are in gum clinic. So it's always better to refer him to gum clinic. Genitourinary medicine clinic. For those who do not know it, gum clinic is genitourinary medicine clinic. So you can refer him to them, and they can start him on medications we call highly active antiretroviral drugs. HAART, H-A-A-R-T medications. Highly active antiretroviral therapy. Combination of drugs which act against the HIV virus prevents it from replication or doubling inside the cells. Before starting these medications, we need to run further tests. to check his liver, his kidney, his blood, okay, and his heart as well. During this medication, it's very important to keep monitoring him all the time, at least every 3 months, to monitor his CD4 count and ELISA, which is a viral load. So we need to monitor him during the treatment, monitor his CD4 count and his viral load as well, how far it progressed. What's next? So this is the medication itself to be given. Please, you will find much information and too much data about it in the script. Try to cut it short, as much as short as possible. You are not in a position to speak about all this in dissertation. You are supposed to say the drugs and how do they react and how to the quotient with these drugs and how will they be given. They can be taken. Okay, now you can tell him about the benefits of these drugs. Usually they are taken lifelong, and thanks to them, the life expectancy of the patients with HIV is quite long thanks to them. Okay, number 2, speak about the follow-up. We are going to follow you up in gum clinic at least every 6 months. And we are going to repeat your tests again and check your compliance with the medication. And have you ever developed any of the side effects or not? Okay. And in the gum clinic, I can offer him some support. Remember, second step is the support. Our third step is support, apart from the follow-up. So second step is follow-up, third step is support. Actually, he may need some counseling sessions and some support sessions by HIV specialists or some counseling sessions like some psychologists. Because after being diagnosed with HIV, the patient will likely lose the confidence and lose many things. So they need some support. After the support, you're going to tell him about partner notification. Partner notification, we need to notify your partner. Doctor, now you offer again, remember? You encourage to inform the wife to come for a sexual health checkup. He will usually refuse. So you can offer partner notification program. What if he refuses? He usually does not refuse. But what if he refuses? In this case, you will offer him that we may need to tell her on your behalf, even if you do not give us the consent. HIV is quite a serious problem. So you need to tell anonymously, even if the patient does not accept. Why? Because she needs to be tested and treated so that you will not get the infection back again. So if he is, sometimes he is a very loving man and he says, Doctor, I'm worried about my wife. And he accepts that that she should be tested and treated. But doctor, how to prevent this from transmitting to her? Now you will tell him that number 1, to prevent hair infection, you need many things. Number 1, you yourself to be treated. So we will start your treatment as soon as possible. Number 2, from your history, if you figure out that he did not have unprotected sex to her. So for example, he did not have unprotected sex with her recently. So you would tell him that she should receive something we call pre-exposure prophylaxis. Pre-exposure prophylaxis to prevent her from catching the infection. This is number 2. Number 3, always she should use contraceptive methods, including the barrier methods. Barrier methods are the most important to be used here to prevent sexual transmitted infection. Okay. What if she was, or what if he had unprotected sex with her? Definitely, you would remove the pre-exposure prophylaxis thing, and you would consider giving post-exposure prophylaxis to her, if this was recently. Okay. What if she wants to become pregnant, doctor? Or what if we want a child? Now your mission is a little bit more complicated. Why? because if she wants to become pregnant, he would need to consider some things. What things? Number one, again, he himself should be tested and treated. Number two, she should be tested and treated as well. She should be tested and treated as well. Number three, she should receive the heart diseases or she should receive the heart medications as well if she is positive as soon as possible. The heart medications are the antiretroviral drugs or antiretroviral therapy as soon as possible. Okay, and if they want to practice unsafe sex, of course, because they want they want her to become pregnant, so it's better always to pick up the ovulation time. To have unprotected sex around the ovulation time, because to minimize the number of the unprotected sex episodes. The chances of pregnancy are always higher near the ovulation time. Okay, so this will minimize the chances, or this will minimize the episodes of unprotected sex, minimize the number of episodes. So advice to do unprotected sex near the ovulation time. Again, Dr. Muniba. Again. So for the wife, to prevent this from transmitting to her, number one, he himself should be tested and treated. Number two, she should be tested and treated if she had unprotected sex with him. But what if she does not have unprotected sex with him? We would give her something we call pre-exposure prophylaxis. Pre-exposure prophylaxis. This is number two. Number three as well, protected sex. Advice about protected sex. Those are the measures to prevent the transmission to the wife. What if he asks you about she wants to be pregnant? If she wants to be pregnant, number one, he himself needs to be tested and treated to minimize the viral load to the zero. If the viral load is zero, by the way, the patient will become not infectious. I can only become infectious if I am having viral load of HIV. But if the viral load of HIV is zero, this means that I'm unlikely to transmit the HIV to anyone. So he himself needs to be tested and treated, and she needs to be tested and treated. Number three, if she is positive, she should receive the antiretroviral therapy as soon as possible. Number four, you advise him that if you are practicing unsafe sex, it's better to let it around the time of the ovulation. Why? Because actually the chance of fertilization are higher at the time of ovulation. So this minimizes the episodes of unprotected sex. Okay. Last thing is that, Dr. Muniba, your question is that if he already had unprotected sex, then what for her? Heart, if test come, yes, definitely she will receive heart. If he had unprotected sex, she will receive heart. She will receive heart if tested and if he had unprotected sex. But the thing is that I need to tell you one thing. He will ask you one important question. Doctor, can she receive these medications while pregnancy? What do you think, Dr. Muniba? Can he receive these medications, or can she receive this medication while pregnancy? This is some confusion. Yeah, she can receive these medications definitely. During the pregnancy, they are quite safe in pregnancy. Not only this, she can receive them, and also they can provide protection to the baby himself, to the fetus himself. They can provide protection to the fetus. So not only they will be beneficial to the mom, no, actually they will be beneficial to the fetus himself as well. She can take them during pregnancy normally. So these are the things that could be discussed in the HIV station, or the HIV treatment. Very simple process. Okay. Anyone got any further question regarding the treatment of the HIV? Has anyone got any further question? Okay, guys, I will take some few minutes break, like up to 5 or 10 minutes break, and we'll be back. We'll start the surgery right after that. Surgery stations for today are very easy stations. Like most of them are back pain. Okay, so please, I need you to have or to know how to elaborate the back pain before we start again, because all of them are the same. We will spend 1 hour in the back, no, like 1 hour in the surgery stations, the remaining surgery stations, and we'll finish them quickly. Okay? Okay, guys, so I'll be right back. Hello, everyone. Are you still there? I see that some people left. Dr. Maria, you are the regular member. What time is it right now there in Bangladesh? Oh, 11:35. Okay, so welcome back, Dr. Mahdi. I can say welcome back to Bangladesh, right? Are you back right now?
Yes, I'm in Bangladesh.
And when will you go to UK?
Inshallah, in the 3rd May.
3rd of May. So this means that you will miss the last lecture, maybe.
No. Hopefully, because I will be there at 10 a.m. so I can join.
Oh yes, that's great. That's great. So okay, and by the way, has any one of you decided at what time they will go to UK? I mean, the people who are outside the UK right now. Has anyone decided or not yet? I mean, Dr. Elvira is in UK. Dr. Zaid, still so long. 27th of May for Dr. Yasmin. Dr. Islam is soon, 3rd of May, I think, or 2nd of May. Dr. Masih, 23rd of May, very enough. A few days, like 1 week before the exam is very enough. Who's Dr. Samsung? Dr. Samsung GT? Who is this? Hello guys, who is Dr. Samsung GT? I mean, Samsung GT, who is this person? I'm sure this is the first time I see this name. Yeah, I know who is this. Who is this person, guys? No, Samsung, not Samsung. Samsung. Dr. I'm going to ask Dr. Samsung GT. I really wonder, can you name yourself and show yourself? Hello? Okay. Removed. Anyone who's not answering may be removed. Tell the call back or tell the message back.
Hello, I'm back. I went and bathed Sophie.
Huh?
I went to bathe Sophie.
You went to what?
To bathe her.
Okay, okay. No problem, no problem.
Sorry.
No, it's fine. I was just asking about the other person. The other person was, I mean, someone who's named like Samsung.
Oh.
Yeah, that's what I'm asking. So.
Which Samsung?
Not Samsung. Okay, wait. Samsung. I'm writing because some people. Samsung. See, check the chat. Samsung, the device. Samsung. His camera was on his, so he is his.
I missed the most interesting bit. Oh.
Yeah, exactly.
It's always like that. Okay then.
Wait, I think this is Dr. Yemi because okay. Okay, let's start. I know your time is treasure, Dr. Masih, and that's why you never waste a single minute. I know this. Brother means brother. Okay, so yes, Dr. Yasmin, it is brother. Yeah, but you know, Dr. Nasir likes to be unique. He likes to has his always different approach for everything. So let's move to the surgery stations. In surgery stations, let's start with the back pain. No, before the back pain, we should start with one subject or one thing which all of you know, of course, and I'm the first one who knows about it, and everyone knows, right? Which the GERD. The GERD, which is like, which is affecting at least 90% of the medical students and 90% of the doctors. So this guy was presented with some heartburn. So this guy again is presented with some heartburn. So the main presentation is heartburn in a guy who is maybe 35 years old, could be. He could be 35 years old. So to elaborate the heartburn, it's very simple. Your FY2 as well working GP. The patient is 35 years old, male patient, presented with heartburn. So the patient is presented with heartburn again. Okay. By the way, today we will remove. I will delay the IV fluid station till tomorrow, and I'll put the Barrett's esophagitis instead of it. The Barrett's esophagitis. It will be put because it's very similar to the GERD, the reflux. So let's delay it till tomorrow, and we will discuss the Barrett's esophagus today. Tomorrow we'll finish the surgery, by the way. Okay, so heartburn, how to elaborate the heartburn? Since when did it start? How did it start? Has it changed? Like this, like any complaint. Here, one question to add. Did you notice that it comes after certain type of food? Why? Because you know heartburn is usually associated with the spicy food, with the hot food, sometimes with the heavy food like fatty food. So those are the things which can bring the heartburn. What could be the associating symptoms? Dr. Nigar, I haven't never heard your voice. So tell me what could be the associating symptoms to the heartburn to any patient. Nigar, Dr. Nigar.
Hello.
Hello.
Yeah, they can complain chest pain, like above near the like upper abdominal pain.
Oh, yes.
bloating.
Okay, what else?
Coughing.
Yes, okay, what else? I need two important things. Okay, let's ask about sometimes we need to ask the most important associating symptoms. What are the most important associating symptoms, Dr. Nigar? Don't you think that we should ask about weight loss? About vomiting,
we should ask about the weight loss. Yes.
Vomiting, tummy pain.
Yeah, vomiting, tummy pain. Yeah.
Exactly. So vomiting, tummy pain, and weight loss, right? So anyone who's having tummy pain, this is usually the symptoms, or these are the associating symptoms. Okay. Okay. So again, dysphagia, for example, difficulty digestion. Very good point, Dr. Maria. Difficulty digestion. Okay, so let's sum up the symptoms of the heartburn again. Number one, heartburn. Number two, I could have some sour taste in the mouth due to the reflux of the acid. When I'm having sour taste in the mouth, I tend to have vomiting and nausea. Okay, and these things definitely can give me some tummy pain from time to time. You know, these disturbances can make me feel sick and give me some tummy pain as well. What are the associating symptoms? I could ask are number one, weight loss. Number two, cough. And number three as well, I could always ask about shortness of breath and tiredness, which are the anemia symptoms. So those are the questions or the associating symptoms to be asked with the reflux. Wait guys, 1 minute. Because I think Dr. Samsung was Dr. Fumbi, and she's texting me right now. Wait.
Guys, we ask weight loss, heartburn, what else? Would you please just list that for me?
Three. Dr. Elvira, the question associated symptoms are weight loss, cough, shortness of breath, and tiredness. Tiredness or to do for the and yeah, cough because of reflux.
Yes, yeah.
Weight loss, and those things are important.
Thank you very much. You're the star. Thanks.
Okay, guys. So this is a reflux. Now let's move to the PMH. Have you had any previous episodes? No. How about your health recently? Did you have any fever or flu-like symptoms? No. You can also ask about any associated bowel disturbances? No. Medical conditions? I think nothing is relevant here. Do you take any medications? He usually takes antacids for it. Only. Family history? Inconclusive, or can happen as well. Lifestyle is the most important questions. Why? Smoking can increase GERD. Lack of physical activity can increase GERD. Heavy diets or heavy meals can increase GERD. And alcohol as well can cause bad GERD. So what are you going to do here to ask about smoking and stress? Very important to ask these things. Those are the precipitating factors for the GERD, for the heartburn, and all of you know. Right, Dr. Muniba? Okay. So now you'll examine the patient, you will do tummy examination. And after the tummy examination, you will tell the patient, doctor, what's going on, doctor? You will tell the, by the way, there is no exclusive or there is no conclusive investigations for the girl. You know this. So we do not need to mention the investigations. I mean, if you ever want to mention something, you just say the initial bloods, like the routine bloods, like full blood count, kidney and liver function tests. One important thing to ask here and never to miss. When you disclose to the patient you're having a condition we call reflux disease. What is this, doctor? It is a condition in which the acid produced from your stomach travels all the way back through your gullet. And that's why you are having this heartburn, because this is acid. Why did I have it? Here, that's why I ask you to be very specific in your lifestyle questions. You would tell him that you have it, for example, because you have been smoking too much, you have been drinking too much alcohol, your diet, all the things can precipitate it. Dr. Muniba, did I answer right thing? Dr. Muniba?
Yes.
My answer was right?
Yes, it is.
Yeah, because you are busy and you are outside, and that's why you're not concentrating on my answer.
No, I was listening. I couldn't. My
Okay.
phone got stuck.
Okay, actually, I have a good idea, guys. When someone asks you why did I get it, always say the reason. I mean the pathophysiology of the disease. Why did I get it? It's simply it happens because there is a weakness in the valve between the lower part of the gullet and the stomach, which means that the acid can travel back again through the gullet. So you understand, usually it is weakness in the gastroesophageal junction. That's why the acid will likely travel back through the gullet again. And there are some precipitating factors for this, like what? Like smoking, diet, alcohol, and physical activity. So here the lifestyle are the precipitating factors, but they are not the true cause. The true cause is a pathophysiology, but other things are add-ons, things which increase the disease or which bring the disease. Exactly, this is a good explanation. Weakness in the door of the gullet, the outer door of the gullet, or the lower door, sorry. So, now what are you going to do for me, doctor? I told you this problem is related to the lifestyle. So there are some things that we can do and some other things that you can do. What would you like me to start with? Tell me, doctor, what you can do for me. Or most of the times he will tell you, doctor, tell me everything. You will start with the lifestyle advice. The lifestyle advice in the GERD patient or in the reflux patient, simply, I bet all of you know about it. Stop smoking. Number 2, drink alcohol in moderation. Number 3, stick to light meal. And please try to eat more frequent meal rather than small, heavy meals. Like for example, take 6 meals per day, all of them are small, better than taking 3 big meals. Do not wear tight clothes. You know, tight clothes will wrap around the tummy and the chest sometimes and will increase the tummy pressure. And when the tummy pressure is increasing, usually the acid will travel to the lower pressure, which is the gullet. So do not wear tight clothes. Try to lose some weight. We forgot to mention the BMI again. So try to mention or try to lose some weight. I told you try to sometimes to skip some type of food which bring on this burn. Like what? Like maybe the caffeine, the tea, like for example the heavy spicy meals, and these things. When you are sleeping, try to sleep on more than one pillow rather than one pillow only. And try to elevate the head of the bed. Why to elevate the head of the bed? You know, when you are lying flat, the chance of the acid traveling back is higher. So when you are lying like lean or you are like sloping, the acid will not travel back away. Okay? So those are the lifestyle. If the lifestyle advices are not helping you, we're going to prescribe you some medication. Which medication, doctor? Now you can speak about the PPI. He will take course of PPI omeprazole for 1 month at least. What after the PPI? You know, if the PPI are not helping him, we are going to refer him to specialist for endoscopy. So number 1, lifestyle. Number 2, PPI. Number 3, if they do not manage him, we are going to refer him to endoscopy. Why endoscopy? Here, it is diagnostic and interventional mostly, but most of the time diagnostic here. So the endoscopy is to find out the reason for your GERD, which could be hiatus hernia in most of the cases, by the way. But we need to find out the reason of the GERD by doing this endoscopy. Now he will be having some concerns regarding endoscopy. Like what? Like, is it painful? We will numb the area and we may give you some mild sleeping medication. Is it painful? As I said, does it have any complications? Is it essential? Because we need to find the reason and we need to treat you properly. Otherwise, you'll be having this heartburn for a long time. If he ever has time in the end, he can ask you, doctor, is there any surgery for it? You will tell him there is some kind of surgery. It is a keyhole surgery, okay, in which we wrap the lower part of the esophagus, the lower part of the esophagus around the upper part of the stomach. I mean, you will wrap the upper part of the lower part of the esophagus around the upper part of the stomach. This way, the acid will not travel back again. So here, the idea of this operation is to reduce the pressure between the stomach and the esophagus so the acid will not travel back again. This is not needed to know, but just know it in case, because you will never have time, by the way, to reach this point. You still have to speak too much about endoscopy. Okay, so this is a station of the GERD so far, and I think no one. Which question? Repeat the question at the start before explaining lifestyle advice. Okay, the question again is that why did I get it? Why did I get it actually? Why did I get it?
Dr. Ahmed,
Yeah,
I mean question which do you want to start with?
What you want to start with? Sometimes he can tell you, doctor, tell me everything. You better here start with the lifestyle. Why? Because the first line of management of GERD is lifestyle. Then if it didn't
Yes,
manage,
I will ask him. There are things we can do for you, and there are things
that you can
you
do
can do
yourself. Yeah.
Oh, yeah, okay.
But the important thing is that you start with lifestyle. Why? Because actually it is the first line. I mean, in the other stations, it is counseling, so it is mutual. Mutual, the doctor and the patient themselves are supposed to do some actions. But here in this station, the first line of treatment actually is of lifestyle modifications. And then comes the PPI. Okay? Okay. So, this is the station of the GERD so far, and it is the ECC station. Yeah, the surgery is the last resort of the management and the GERD, Dr. Yasmin. What else? Next station is the Barrett esophagitis. The only difference between this station and the GERD station that the patient in the task, it says that the patient has been diagnosed with Barrett esophagitis and he has been scheduled. I mean, the endoscopy has been done to him and everything has been done, because the Barrett esophagitis is diagnosed with microscopic report or microscopic examination. So he has been scheduled to have endoscopy every 3 years. It is written in the task itself that he's scheduled to have endoscopy every 3 years. So what could happen here? Again, the same thing. Okay, how can I help you today? Doctor, I'm here because they sent me for the follow-up. This guy has gone to the medicine, or he has come from the medicine department to you, and he has undergone endoscopy. And sorry, you are FY2 in medicine department, and the guy has just had endoscopy, and the endoscopy has shown Barrett's esophagitis. So in this case, actually, you are supposed to talk to him and disclose the test results and endoscopy results to him and address his concern. Especially know the patient has been scheduled to have endoscopy every 3 years to follow up the Barrett's esophagitis. Here you will start with him. How can I help you? I am here for my test results. Okay, I have your test results. I need to have let's have a quick review about your health. Yeah, know why did you have these test results in the first place, and then he will give you the heartburn. Again, the same approach, same symptoms: cough, shortness of breath, sour taste in the mouth, acid reflux or burning sensation in the chest. He told you heartburn already. So some tummy pain, ask about it. Very important to rule out weight loss and shortness of breath. And you can also ask about, for example, peptic ulcer, like any blood in the stool. Okay, now it is very similar to the past station, but when you come to disclosure, by the way, the guy will tell you in the history that he was diagnosed with reflux before. So definitely he has long-standing course of reflux. Definitely, guys, that long-standing reflux for more than maybe 10 to 15 years can lead to Barrett's esophagus. So you will disclose to him that the test results show that you are having a condition we call Barrett's esophagus. What is the Barrett's esophagus, guys? Barrett's esophagitis is a condition in which the lower lining of the esophagus, the lower lining of the esophagus is altered. How is it altered? Dr. Muniba. Dr. Muniba?
Yes.
Can you tell me what's Barrett's esophagus?
Basically, it's the change of lining of the lower part of esophagus from the squamous to the columnar.
Okay, perfect. You will tell the patient squamous to columnar?
No, it's just a change of lining, which is not actually good.
Flat cells to tall cells.
Yeah.
Flat cells to tall cells. So from the flat cells to tall cells. Okay, Dr. Muniba?
Yeah. Okay. Yes, sir.
Okay. Okay, so this is the most important thing in explanation. So he will ask you this question, Dr. Muniba. Oh, wait, please. Wait a minute. I'm sorry. Wait, please. Sorry. Dr. Muniba, tell me.
Yes.
Is it cancer or is it cancer, doctor?
No, it's not cancer, but if it's not treated at the right time, it can lead to cancer. It's a pre-malignant. Basically, it's a pre-malignant condition. We can't tell that to the patient, but
you can't tell this to the patient. You're going to lie to the patient.
I said we can't. We cannot.
No. Wait. No, just Dr. Muniba, I have to disagree at this point. You know what happens? Barrett's esophagitis itself is not cancerous. It is, it is not cancerous. Okay, let me tell you something. It is the cells which undergo Barrett's esophagitis are likely to undergo dysplasia, which is abnormality in the shape or in the content, the structure.
Yes.
So the cells which undergo Barrett's esophagitis are unlikely to have dysplasia, and after dysplasia itself is cancerous. So they are high likely to develop dysplasia, but the dysplasia itself is cancerous, but not the Barrett's esophagus itself.
Yes, we can say that it's not cancerous, but it can. The cells there is increased risk of them turning into cancer cells with time.
Perfect. Oh, Dr. Muniba, again.
Yes.
Say it again. I'm sorry. Say it again, because I didn't like the last part that you said. Say it again.
Basically, if the patient would say that is it serious or is it cancerous, we can say that it's not cancerous, but the cells that has changed their shape, they have there is increased risk that they can turn into cancerous cells with time.
Yeah, exactly. Thank you.
Agreed now?
Agreed now. I'm happy now.
Okay.
Release.
Okay, thank you.
Okay, as if you are sending me a gift, or you are offering me something by answering right. Thank you, Dr. Muniba. Thank you so much, really.
You're welcome.
I didn't mention cancer at all. Yes, Dr. Maria actually has got very good point. Dr. Maria has got very good point, May, and Dr. Zaid as well. May I know why? May I know what's your concern? I didn't mention cancer at all, just say the repeated exposure to the stomach acid has caused cells to change, and it's called 333. To monitor the change and make sure that it is something serious. Okay, that's fine. Dr. Safa, that's fine. But what I'm saying is that you can also say what I said, that it is just, the cells which develop Barrett's are at risk or higher risk than other cells to develop condition we call dysplasia, which is change in the color or change in the shape and the structure of the cell. And this can put them under risk of developing something serious. What you said was right, definitely. I don't have a problem with it. The doctor say, may I know why you think so? This is a very good point. This is a very good question not to miss. May I know why you think so? I'm glad that everyone is repeating this question. Okay, so what is the plan for now? What is the treatment of the Barrett's esophagitis, guys? Can anyone tell me the treatment for? So now you explain to him the condition and the impact or the complication. What is the treatment or the management plan for Barrett's esophagitis? Can anyone volunteer and tell me 1 minute, please? Less than 1 minute, because we need to do the back pain stations and we will be done for today. The dysphagia still, this is still dysphagia station. So
can I play?
Yeah, sure. Anyone? Dr. Zaid, tell me, Dr. Zaid.
Well, we do have a non-medical option and a medical option.
Yeah.
So what do you think you would like to start with?
Start with lifestyle. Yeah. So again, the treatment is the GERD treatment, right?
Yeah.
Okay, what about the follow-up? Which follow-up you will do to him?
Well, we'll also need you to be followed every certain number of years.
3 years. It's 3 years. Yeah. The task is 3 years.
So if I'm not sure, can I link it to or refer it to according to the?
No, wait. It's written in the task. It's written in the task.
Yeah. Okay.
The tasks or the report say that he should be followed every 3 years because it differs from one person to another. Okay. And from one grade of Barrett's, one grade to another.
Okay,
so
thank you.
3 years, every 3 years, follow up by endoscopy. This is the whole thing. A very easy station. Just one point to know: what's Barrett's esophagitis and what has caused it in the patient. Yeah, the letter will be showed to you. Surveillance tests is every 3 years. Okay. Next station is, anyone has got any questions regarding this station? Anyone has any question again regarding the past 2 stations? Okay, let's move to the next station, which is the dysphagia. Dysphagia station, guys. In dysphagia, you know what is the presentation? The guy will come and tell you, doctor, I'm having indigestion. Indigestion means that he's unable to swallow, maybe. He's unable to eat generally. Why? Because this dysphagia is definitely, you know, he's old age guy. He could be 60-something years old, and your FY2 working in GP, the patient is having indigestion. Talk to the patient and address his concern. So, in this particular case, what can we do? Doctor, anyone, I need anyone to tell me. Doctor,
I can do that.
Dr. Masih, finally, welcome back. Dr. Masih, I'm having indigestion.
Okay, and could you please tell me exactly what do you mean by that?
Like, lovely, Dr. Masih. Applause, really. Seriously, I like it. Why?
Because I don't know what is indigestion.
Exactly, and we never know. You never know till you ask him, and neither do I, and neither anyone do I. But some people will keep, because they know the script. Some people, because they know the script, they will know that here he means indigestion and he means like dysphagia. So I should proceed with, and since when it started and how did it start? No. When someone is giving you indigestion, when someone is giving you some, for example, unwellness, when someone is giving you dizziness, when someone is giving you any vague complaint, please ask him, you know, what do you mean exactly by indigestion? I don't know. Seriously, I don't know what's indigestion. Maybe his problem is that he's having sore throat. Maybe his problem is that he's having something stuck in his esophagus. Maybe he's having problems with like some burning sensation. So I don't know. I don't know what's wrong. So, in this case, actually, he will elaborate it. He will tell you, doctor, you know, I'm having problem like eating for example, I'm having problem eating certain types of food. Which type of food? You know what? In the beginning, he used to have a problem with the solid food. But right now, he's having problem with the solid and liquid food. So this guy is having progressive dysphagia. You will ask him, what do you mean? And then elaborate it. You will find that it started by the solid food and right now solid and liquid food. Or solid and semi-solid food, sorry. Not liquid. When did it start? Has it changed? Like normal elaboration. What are the associating symptoms here? Do not ever forget to ask about number 1, tummy pain. Number 2, heartburn. Number 3, very important, weight loss. Weight loss is very important in this station. Sometimes he can give you, some other times he may not. Weight loss, loss of appetite, any shortness of breath, any tiredness. These things actually are the most important questions here because you know this is a guy is a high possibility of esophageal cancer. Have you noticed any lumps or bumps anywhere in your body? No. Move to the past medical history again. So again, the questions are very similar to the past stations, the GERD stations. Because actually GERD is one of the precipitating factors, long-standing GERD is one of the precipitating factors for esophageal cancer. Long GERD, you know, long GERD leads to Barrett's esophagitis, and Barrett's leads to dysplasia, and dysplasia actually may lead to the thing. So the thing is that here in this case, you have to take past medical history. Have you had any similar episodes? How was your health recently? Apart from that, any medical condition? Do you take any medications apart from that? Any allergy? Any family history of any problem? Any family history of similar problem? Usually, no. Lifestyle, very important in any digestion or smoking problem to ask about the lifestyle. It can be the core of the station. It can be the reason why this patient has developed such problem. Do you smoke? Do you drink alcohol? How about your diet? And are you physically active? Are you stressed? Do you have stress? Now examine the patient. Most importantly, tummy examination. Do some investigations, only routine bloods here. Okay, do you have any idea what's going on? No, doctor. From what you told me, it seems that you're having a problem in your gullet. Or in your gut. Say in your gut better. Problem in your gut. Or gullet. Whatever. Which problem, doctor? Now you don't know what to say because you know there's here high possibility of cancer. So at this point, actually, it's difficult to say. However, we need to run further investigations to find out the reason. Which investigations, doctor? Remember the lung? It's definitely like the lung stations. We need to run further investigations, including number 1, we're going to do some scans like CT scan and X-ray. Number 2, we can do some, or we can refer you to one specialist to do procedure to take a sample from your gullet. Again, we are going to do some scans, normal scans, and we are going to refer him to one specialist to perform the endoscopy. Why endoscopy? He may ask you some questions regarding the endoscopy because we need to find out the reason and take a sample. And what else? He's going to ask you a few questions at the end. Like, for example, doctor, what about my feeding? This is a very important point. In this station, the guy actually, he can tell you in the beginning that he is not able to eat anymore because of this problem. So what could be the complication of not eating for a longer period, Dr. Maria? Dr. Maria, this guy cannot eat properly since a long time. What could be the reason here?
What could be the reason?
No, sorry, what could be the complication?
Okay, complication would be weight loss, shortness of breath, tiredness, the anemia symptoms?
The complication, one of the most acute complications.
Um, mm, Acute complication. He's able to take solid and semi. Not able to take solid and semi-solid, right?
Your husband has beaten you here. Your husband brought dehydration.
Yeah, but he can take liquid, right?
Well, dehydration is not
He's
only
unable
about
to take
liquids.
like solid and semi-solid.
No, dehydration is not only about liquids. Okay, I mean sometimes when you are able to take liquids, sometimes still you can have dehydration because you are not eating properly. Maybe his appetite is lost and he cannot take anything. So you should always ask this question: have you felt dehydrated? You should always ask this question for someone who's not feeling well for longer time. By the way, if you remember, there is a station which we did not explain yet. It was one of the one of the stations in the mid session, which is a guy. He was one guy. He was confused, and he's having dementia, and he's having hypertension. And so this guy, due to the dementia, he forgets to eat his food, and at the same time, he's taking water tablets. So the water tablets from one side and the lack of food from the other side brought him dehydration, and the dehydration could have brought him the confusion. Together, dehydration is usually associated with hyponatremia. So again, do not forget to ask about dehydration for anyone with prolonged feeding problem.
Okay.
And in the bronchiolitis station for the pediatrics, we will ask this question as well for the dehydration, because the guy or the baby is not feeding properly since 2 or 3 days. He's not feeding at all, actually. So, again, you will tell him we do some further investigations. Okay, which investigations? We said some scans or camera tests, and after that, some scans, and after that we can refer you to specialist for a camera test. Some advices. You will advise him now about the smoking. Advise him about the diet. Doctor, but I cannot eat. See, you can give him some few options, very simple options, like what? Stick to the light meal. Like for example, some puree, some smashed food, some jelly food. Okay? Stick to the simple meals like the smashed meal, like sauté, like puree, like these soft food and smashed food. Okay, so he has to stick to them for the time being, at least till we find out, or till we perform these investigations and find out the exact reason and treat it. So again, this is a possibility of cancer. By the way, he may ask you one question in the middle. Doctor, is it cancer? What could be the answer here, Dr. Maria? Is it cancer?
May I know what is your concern?
Doctor, because my friend, doctor, he was having similar symptoms and he was diagnosed with cancer.
Oh, I'm really sorry to hear about your friend. But in your case, we can't say right now, I'm not in a position to tell you right now that you're having a cancer or not, because for that reason, we need to run a lot of tests. And I'm going to assure that. And I have to consult with my senior.
No. Okay, wait. One point to here, Dr. Maria.
No, we need to run some further tests, like some scans, X-ray, and refer you to the specialist for a camera test and take a sample from your gut.
Perfect. One important thing, Dr. Maria, do not tell the patient that at this point I cannot tell you if you have cancer or not. This may sound too tough.
Yes, I just like mixed it with the ethics station.
No. Even in the ethics, you cannot tell at this point. I cannot tell you if you have cancer or not. Just say that at this point we don't know. That's why we are going to run further investigations. If I'm telling you, I can't tell you if you have cancer or not. This is too tough sometimes, too direct.
Okay.
So you better tell him that at this point it's difficult to say. For that we need to run further investigations.
Okay.
However, cancer could be a possibility. So, doctor, Sometimes he can ask you anything else, like for example, how are you going to treat it? Sometimes if it is confirmed to be so, we need to remove some parts of the gullet and attach or to connect the remaining parts back again in place. Yeah, it's cancer could be a possibility. However, cancer could be a possibility in the worst case. Yeah, we can, Dr. Masih, actually how to rule the structure or how to rule the spasm and how to corrosive agents. Corrosive agents, you can ask simply, have you had any like maybe acid or like maybe very hot meal? So you'll ask the patient, have you ingested HCl recently? How to rule out structure and spasm by one question, Dr. Masih.
Like, does your symptoms get worse when you have a hot or cold beverage?
Excuse me, symptoms get worse what?
When you have a hot or cold beverage.
Okay, so you'll ask him about like hot or cold beverage, and if they aggravate the condition. This is a good point. Okay, this is a
Hello.
station.
Okay. In this station, like in dysphagia stations, it is very obvious that the patient might have cancer because from the history and yes, weight loss and everything is goes to cancer. So I guess we should not be tell like this. Okay, we have to run some tests. Okay, we should, but I guess we should be more focused toward cancer, because if we don't say the diagnosis, the examiner can't understand that we are able to diagnose cancer or not.
Well, this is a good point, but you know what I recommend is that actually you will let the patient say the cancer himself. I mean,
yes, of course.
I mean, he will definitely be concerned about cancer. So at this point, by the way, you do not have other symptoms. You just only have dysphagia. So the dysphagia only, okay, it is a suggestive, but it is not a good clue to say it.
Okay, but I had a patient like has a squamous cell carcinoma in the forehead.
Yeah. No, this is something else. This is something else. You know why? Because this patient was having a change in the skin lesion, and he was having bleeding, and he was having sometimes ulceration, and it was increasing in size, and he was so many findings which point out toward the cancer. He was exposed to the sun for a long time.
Yes, and I had maintained a good communication with him. He's a very nice guy. I guess he's the best simulator out of 18 stations in my day. And he's more than 50 to 60 years old, very good person. And I talked with him so friendly. And at the time, I used the best case scenario and the worst case scenario method. And unfortunately, I got 1 and 1, ultimately 2. I thought I would get 12, but unfortunately I got only 2 but I think that because I didn't tell that this is a cancer or this could be cancer, I just told boldly, okay, at this point we can't, what Dr. Maria told you, I just told that because we need to run some tests, we need to run some biopsy, then we can understand, we can able to diagnose this condition, but it's not possible to tell now. I told this.
Actually, here you are mistaken for a reason. Because here in the cessation of the skin lesion, by the way, we are going to discuss it anywhere tomorrow. But in the skin lesion station, the squamous cell carcinoma, particularly and the basal cell carcinoma, you are supposed to tell the patient from the beginning. It seems to me a bit serious.
Well, okay.
It seems to me a bit serious. Why? Because now you have many clues. Why many clues, Dr. Elvira? Dr. Rivera, no, don't worry. They are not deceiving. I will tell you something. Let's speak clinically. In this station, you are having a photo of the skin lesion by your eyes. And you are having many suggestive symptoms, at least 2 or 3 suggestive symptoms of cancer, like the bleeding, like the increase in size, like the change in shape. So many clues which point you toward cancer. So and beside the skin lesion photo itself. So you are going to tell the patient, it seems to me a bit serious. Yeah, why serious, doctor? You'll explain to him that it's changed in size and in shape and in color, and you have been exposed to the sun for long. And these things don't happen usually in the benign lesions. Doctor, is it cancer? May I know why you think so? Because you told me it can be this and that. Actually, cancer could be a possibility. I'm afraid that cancer could be a possibility here. However, we need to do some further investigations for that to confirm. For that, we're going to refer you to one of the two specialists or team of specialists which are going to decide on it. If the simulator is friendly, I mean, no guys, there is no rule for it, but this is what I notice sometimes, seriously, that if the simulator is friendly, sometimes this means that you are in trouble. Sometimes, I mean, do not rely, I mean, no, generally do not take the simulator friendship or friendliness as a rule. I mean, do not take it for granted, okay? This is something else. Okay, so this is a station so far. Here, you have no other clue for cancer. So what you are going to do is that you are going to say that you are having problem in your palate for which we need to run further tests. Which test? You are mentioning the test. Doctor, could it be cancer? May I know why I think so? Doctor, because one of my friends, actually cancer could be a possibility here. This is a very good point. Now let's move to, Dr. Mahdi, you need to add something? Okay. Yeah.
So we will not think or say about any pH monitoring or upper GI series or gastroscopy here there. Directly to endoscopy, because dysphagia can be at any level. So you need to put out in history, isn't it?
Excuse me, I didn't get you.
For the this is the dysphagia station. So
yeah.
far as we generally do first, like in the history, you are elaborating like dysphagia. What do you mean by that? Okay. So it's a difficulty in swallowing. It's a problem in food pipe. So it is at the beginning of starting of the swallowing or middle or lower part, then he will or she will show the position situation. Then he'll say that, okay, is it for the solid food or liquid or both? Is it progressive?
Yeah.
And then initial test doesn't include the pH monitoring and upper GI series, then later endoscopy, or directly going to the endoscopy.
And by the way, Dr. Yasmin, endoscopy is also for the upper GI.
Okay. So no initial test. We are not doing any initial test here, right?
Like what? Like the bloods?
No, the pH monitoring.
pH monitoring, you can consider it as well like the pH, but pH is more like to wear the GERD. If there's a GERD like heartburn, because you know that the heartburn.
And what about
yeah,
barium swallow as well?
Yeah, upper GI series by barium swallow. That is what.
Well, actually, what I suggest is that it's apart from being old, Dr. Zaid, these things are usually to detect any like abnormality in the structure of the esophagus, like maybe any narrowing or any structure or anything. You can consider them as well barium swallow, but the barium swallow and the pH monitoring are not usually used in UK, by the way. The thing which is directly used in UK is endoscopy, but you can mention it. We can also perform some tests which is done with a certain type of dye called barium swallow to detect if there's any problem. But I mean, it's not a big deal.
Yeah, just to see the endoscopy. I'm just wondering about that, how to by asking questions about achalasia, spasm, those questions in history, then you go directly to endoscopy, or you got history questions positive for cancer. That's why you are jumping directly to endoscopy. That's the question.
Yeah, actually here, it's definitely, it could be, I mean, from the history you pick up that it could be a possibility of cancer. But anyway, it's not a big deal if you mention like barium meal and such things. But the most important thing is to tell him that we need to run endoscopy here. The endoscopy is the core of your diagnosis here, actually.
Yes, definitive diagnosis. Okay.
Yeah. So let's move to the other station, which is quite similar to them, the hematemesis. The hematemesis station. The hematemesis station, guys, okay, this station is quite like some people may confuse it with the GERD. What are the reasons for hematemesis? You remember, guys, the same man upper GI bleeding? Remember the same upper GI bleeding. It's very similar to this station. So here in this case, what could be the reason for the hematemesis? Number one, painkillers, especially the ibuprofen, anti-inflammatory painkillers. Number two, too much alcohol. Right? So those are the most important causes for the hematemesis. Definitely, there could be a liver problem sometimes, but I mean, in young age, like maybe like 27 years old girl, probably the most probable cause could be what could be here alcohol intake and painkillers. Why painkillers? Maybe she's having prolonged headache. And why prolonged headache? Could be tension headache. Could be anything. Okay? So let's start quickly with this station. She is having hematemesis. Elaborated the hematemesis. She is vomiting the blood. Elaborated, like for example, since when it started? How did it start? Tell me about the blood. Amount, color, any blood clots. What about the content? Any change? Usually she's having episodic hematemesis, not only one single episode, but this time it comes much more than any previous episode, and that's why she is concerned and she came here. What could be the associating symptoms? Again, similar to the past ones. Number one could be tummy pain. Number two, she's already having vomiting. So ask about any, maybe any cough, any shortness of breath. What about any loss of weight, for example, in the past few days? So very similar to the GERD stations as well. Move to the past medical history here. Past medical history is that, have you had a similar episode? She already told you that she had similar episodes. So how about your recent health? Please rule out cancer here. Very important to rule it, and try to rule out peptic ulcer disease. How to ask peptic ulcer? Did you have any bleeding in your stool or any dark stool? Any bleeding elsewhere in your body? Did you have any weight loss? Any loss of appetite? Any shortness of breath? Any tiredness? So here in this case, you'll ask her, do you take any medications? This is very important. Yes, I take some ibuprofen because I'm having some headache from time to time. How much do you take? She's usually having prolonged history or history of prolonged ibuprofen intake. And she increased the dose recently. Why? Because the headache is getting more worse. Any allergy? No. Family history? No. Lifestyle, very important. She can be a heavy smoker, which can worsen her stomach problem. And she is drinking alcohol. She binge drank alcohol last night, and that's why the attack was severe. Diet, physical activity, ask about them. You can also ask about the period, like when was your last menstrual period. Okay, let's move to the examinations. You do tummy examination, and you may or you may not find some tenderness. Usually there is no tenderness in the epigastric region. Examinations or investigations here, only initial bloods. Routine bloods including full blood count, liver and kidney function tests, and ABGs, and very important to ask for the clotting screen. Clotting screen is very important. Why? Because you need to know the extent of the bleeding. So what is the management? You're having condition we call hematemesis, vomiting of blood. Why did this happen to me? From her history, you will find that she is taking ibuprofen, which will irritate and damage the lining of the gut together with the alcohol. These both things can cause erosions and ulcers in the gut. So alcohol and painkillers cause erosions and ulcers in the gut. What should I do right now, doctor? We are going to keep you in the hospital right now to have a closer look at you. I'm going to ask my senior to come and review you. Here in this case, we need to give her many things. Remember the DKA? Still here, we need to give her many things like the DKA, but not similar to the DKA management, no, many measures. Like what? Number one, you need to give her IV fluids in case she is having any hypotension. Number two, we may consider giving her, we need to perform chest X-ray and abdominal X-ray to her. Why abdominal X-ray and chest X-ray? To see if there's any perforation. We may consider giving her PPIs. Okay, Dr. Kashi, you can leave right now. You can give her PPI. But the most important thing is that after the abdominal and chest X-ray, you need to do ECG as well. Why? You know that this bleeding can cause bad tachycardia. After the ECG, you need to move her to the endoscopy. So again, number one, you're going to give her, admit her and inform the senior. Number two, IV fluids. Number three, some abdominal and chest X-ray to see if there's any perforation. Number four, yeah, okay, Dr. Masiha, I will speak about that. Number four, you're going to move her to the endoscopy as well. Why endoscopy? I mean, you will ask or you will refer her to specialists to perform endoscopy. Why? Because the endoscopy is to detect the site of the bleeding, and also we can inject something to stop the bleeding. So here it is diagnostic and interventional. So the endoscope is very important here. Actually, it is a definitive management here. Okay, sometimes you can add something and you can tell her we may also consider giving you some medication to stop the bleeding temporarily. Like those medications like what can I say? I don't remember the name actually. But just you can give her some medication to stop the bleeding, like those vitamin K, I think. Vitamin K medications like, I don't remember the name, but this is what we used to give. But just say the most important thing is the endoscopy, because we can.
Transamine.
Yeah?
Tranexamic acid.
Yes, octreotide, yes, and tranexamic acid. But I think octreotide is more. Yeah, octreotide here is more. Not fresh frozen plasma, because I do not consider it as hypovolemic shock. Dr. Muniba, when someone is having tachycardia after bleeding, what could be the reason here? Or what could we do here?
Basically, we can give IV fluids to them.
Yes, exactly. So here the first line of the management is IV fluids, right?
Yes.
Okay. So here she's having some concerns. You can ask her about blood thinners in the history as well, if you wish, like any bleeding we said before, any blood thinners, any instrumentation, any injury, like this. But I mean, I'm just picking up the most important and the most relevant things. Okay, now she will have some concern actually regarding the endoscopy and hospital admission. You will tell her that we need to keep you in the hostel, because actually you will tell her first, may I know why? She will tell you she needs to pick up her children, for example. I can imagine how it can be frustrating, but we need to keep you here because we need to refer you to specialist, and the specialist needs to do some endoscopy camera test for you. Now we'll explain the camera test to her and why we need to do it and why we're going to, or how we are going to use it to stop the bleeding. What's next? Here in this case, actually, you will, in this case, you will ask her to do the H. pylori test, the urea breath test here as well. So also she will consider urea breath tests. So she will consider again urea breath test. In the hematemesis, we consider urea breath test. Urea breath test, if it comes positive, she will consider taking the triple therapy. Triple therapy for H. pylori. 2 medications for 1 week and PPI for 4 weeks. So again, urea breath test after the endoscopy. I mean, if the endoscopy comes back normal, we will do urea breath test. If the urea breath test, is inconclusive, if the urea breath test is conclusive for H. pylori, she will receive the H. pylori eradication therapy for 1 month. And after this month, actually, we will follow her up again with H. pylori test. Meanwhile, we can give her some advice regarding the smoking and the alcohol and the painkillers. So again, endoscopy right now, and then H. pylori test. H. pylori to be repeated after 1 month. Okay, or sorry, after 45 days. Why? Because I'm going to give the treatment for 1 month, and 2 weeks after the stop of the treatment, we're going to repeat the urea breath test. This is the station so far. The treatment is the treatment of the hematemesis, and it comes as the same man nowadays, but generally try to revise it again. Why? Because the treatment is very simple, but she's reluctant to stay in hospital. So you have to convince her to stay in hospital because we need to do this endoscopy, at least within the 24 hours, within the first 24 hours. Okay. So let's move to the next station, which is the back pain. I used to like the back pain stations. What's wrong with the back pain? The back pain is very similar in all the stations. Let's speak about all of them in one go. We need to finish all of them in half an hour because we are still remaining with half an hour in our session. Okay? So here, let's start with the back sprain, the easiest one. Especially in the muscle sprain, what do I expect in the back pain and the muscle sprain? Usually it is sudden pain, which started, okay, by the way, guys, in the next stations, remember the headache stations when we first started our course 9 days ago? I used to ask all of you about how to differentiate the type of headaches from each other, because recently I know that many people are confused about the back pain, just because they are confused between muscle sprain and cold equina and this prolapse and maybe aortic aneurysm, this thing. So I need you to know the difference between all of them right now. So I'm going to pick up someone each time and I'm going to ask him, I'm going to give them finding and they will tell me what could be the reason or what could be the diagnosis. Okay? It will not take any time. Dr. Masih, it will not take you any time. Yeah, I know. So let's explain how to approach the back pain stations quickly. Okay. Some people have been asking about the approach of the counseling stations, the general approach. I sent the audio for the counseling stations, how to approach them. Please, guys, listen to everything and you try to make your own notes. I told you I will send the notes, I mean the ethics and some of the counseling stations in the end of the course. Okay? No, Dr. Zaid, it cannot be pancreatic cancer. Yeah, you mean you reached pancreatic cancer. This is what you reached. But actually it is prostate cancer. Right?
He asked me when I reached to the management and I asked him, do you have any concern? He said, well, one of my friends, he had pancreatic cancer.
Yeah.
Could it be the pancreatic cancer? So I told him I returned back to the family history, so I spoiled all the... Yeah.
No, actually, okay, I'm coming to this question soon. This is a station of back pain and the elbow. Okay, so let's just give a general approach to the back pain station. You will elaborate the back pain. Okay. Elaborate the back pain very well in terms of, I will point out the difference between them right now when I'm going to ask all of you. But what are the associated symptoms to the back pain? The associating symptoms could be, number one, any muscle spasm or any swelling in the back. Number two, ask about UTI symptoms, urinary tract infection symptoms. Number three, neurological symptoms. What could be the neurological symptoms? Could be like weakness or tingling or numbness in the legs. Number four, ask about any loss of sensation in the back passage or around the back passage. Okay, again, muscle spasm or tightness and injury as well. This is the first associating symptoms. The first associating symptom. Number two, UTI symptoms. Number three, neurological symptoms in the lower limbs. And number four, the neurological symptom or loss of sensation around the back passage. Please mind these all questions and ask them in any back pain, except only one station which we are going to discuss right now. Okay, so now we will ask the patient in the past medical history about any previous episodes, how was your recent health. Ask him about the cancer symptoms. So ask about the cancer symptoms in the recent health, and could be the prostate symptoms as well, if he's old age. So add that if the patient is old age, I need to ask about cancer symptoms and prostate symptoms. What are the prostate symptoms? You're going to ask about any urgency, any frequency, any hematuria, or any nocturia. Again, urgency, frequency, poor emptying could be. Just ask 2 or 3 questions ultimately, like, are you able to empty your bladder totally or completely? Do you think you need to wait before your urine starts to flow? This is hesitancy. You know why hesitancy happen? Because actually when there is like any blockage or any hurdle in the urinary pathway, usually the urine does not pass smoothly. So in case of any tumor, the urine pathway will not be smooth. So any hesitancy? Okay, any hematuria, any blood in your urine. Why? Because if there is any tumor or any growth, it will irritate the blood vessels in the bladder. So this will cause hematuria. Okay, so prostate symptoms and cancer symptoms for old age. Medical conditions not conclusive. Maybe only if he had any previous urinary tract infections. Ask about family history of cancer, prostate, or bladder, very important. Ask about the lifestyle questions. Actually, the chance of getting cancer increased by smoking. Please do not forget it. So number one here in this station, after this, we are going also to ask the patient how about his job and if it involves heavy weight lifting or not. Why? Because I need to rule out the back sprain or the disc prolapse as well. Okay. So let's now move to the examination. In the examinations, I have to ask the patient about the vitals, and please, you will mention number one, vitals. Number two, general physical examination. Number three, abdominal examination, because the abdominal examination includes back examination. So in any back pain, you need to examine the tummy as well. Then back examination, which is part of the abdominal, okay? In the back, please do not forget to mention straight leg raising test. I will write it for the people. I will write it to everyone. Straight leg raising test for the people who do not know it. Straight leg raising test. Again, straight leg raising test. Why? Because I need to exclude disc prolapse by asking this question. Okay, so After that, I can also examine the back passageway to see if there's any prosthetic problem. Okay, let's speak right now about the back pain in details. Okay. For the back pain, again, we need to elaborate the back pain. We need to ask the associating symptoms, which could be number 1, muscle spasm or tiredness or injury. Number 2, UTI symptoms. Number 3, neurological symptoms in the lower limbs. Number 4, any sensory loss around the back passage. Okay, then now ask the past medical history. In the recent health section, if the patient is old age, it's very important to rule out prostate symptoms and cancer symptoms. Now you ruled out the DDs, move to the lifestyle. Ask about smoking, very important. Ask about job as well, very important. Do the examinations. The important examinations to not forget are the abdominal, the back examination, including straight leg raising tests, neurological examination of the lower limbs as well, and examination of the back passage. Those are the stations of the back pain. Let's try them quickly. Dr. Masih, let's start with you. Are you ready?
Yes, brother.
So if the back pain started maybe yesterday morning and it's getting worse, it is on one side of the back and it's dull aching pain. I have tried some paracetamol and it didn't help me. I am 25 years old male and this pain started suddenly when I was waking up from the sleep. I don't have any urinary symptoms. I don't have any neurological problems nor sensory loss in the back passage or around the back passage. And definitely, since this back pain started 2 days ago, no need to ask about my weight loss and prostate symptoms, because already I'm 27 years old male patient. But when you ask me, have you had anything or how did it start? Or have you had anything unusual? I would tell you, yes, doctor, I was playing golf. Or I was playing tennis after a long time.
Back sprain.
Huh?
Back sprain.
Exactly. This is back sprain. So now I hope you know what is a back sprain. It is related more or less to the physical activity. Okay, this is quite straightforward station, the back sprain. But still you have to do all the examinations that we mentioned, and you still have to do which investigations, by the way. Investigations here are the initial blood and x-ray on the back. Initial blood and urine and x-ray on the back. Are we clear so far? So what is the back sprain, Dr. Mahdi? Sorry, Dr. Masih. Sorry, Dr. Masih, what is the back sprain?
Like an overstretch of the back muscle?
Exactly. It is a condition which is the back muscles or a pain due to overstretch in the back muscles, like what happened to you when you played tennis after a long time. What could be how can we diagnose it? I mean, how can I be sure that this is back sprain and nothing else?
By straight leg rest test.
And
I don't know. Like, I don't know. What's the next one?
Do not surrender. Do not lose hope. Tell me. Don't say I don't know. Just try to think. Think about it. Don't you need to do the X-ray? The X-ray on the back?
Yeah, you can do that.
You will do the X-ray on the back, and from the straight leg raising test, and there is no neurological symptoms. This means that it's definitely It's definitely back sprain, right? So you would tell him that this is back
sprain. Will be positive here.
Is negative, definitely. Straight leg raising test is negative in the back sprain, No need to do it, actually. I mean, no need to mention it. Sorry, no need to worry about it. Because straight leg raising test is definitely here, in this case, it's negative in the muscle sprain. Okay, again, you are having condition we call back sprain or back sprain. What if the structure physical condition which the muscles of the back are overstretched beyond their limits, and that's why you experience it or are having this pain? Why does this happen to me? Because you played tennis after a long time. Okay. Doctor, how are you going to treat me? Now the treatment simply some painkillers and lifestyle advice. Remember the chest trauma guy? Here, painkillers and some simple painkillers to take, and some lifestyle advice. Have enough rest with simple exercise only. Why? Because simple exercise can fast your recovery, or can enhance your recovery as well. It's advisable not to do any physical activity, any strenuous physical activity. Just try to give yourself some time till you recover from it. If he asks you for how long, you will tell him it differs from one person to another. However, it can take you up to 4 weeks. So any sprain can take 4 to 6 weeks. But it's just always mention in the beginning that it differs from one person to another, and your healing power differs from another person. Okay? However, we recommend 4 to 6 weeks to back to any strenuous physical activity.
Any warning sign?
I'm going to tell you everything. So here in this case, he will ask you, doctor, couldn't it be disc prolapse? May I know why you think so? Doctor, I'm just worried about it because I've heard about it too much. Now you can ask him, what did you hear? He'll tell you that doctor is having back pain and this bad back pain. He will tell you anything. Now you have a very good reason to say that no, it is not disc prolapse. You know why? Because number one, your symptoms do not have any other symptoms of disc prolapse, like no weakness in the lower limbs. Number two, the examination, we did some examinations which shows no straight leg raising test. I mean, we straighten the leg or we raise the leg if there's any pain produced in the back, and it was negative. However, we are going also to refer you to for further investigations. Which further investigation? You are going to refer him for MRI. So this guy will have the initial investigations, and after a while, you will refer him to MRI as well. Why? To rule out other causes. However, he doesn't have any symptoms, but for any sprain, you have to be safe. You did the initials, including the X-ray, but still you have to follow him or to move him to the MRI here, just to make sure.
Can I ask a question?
Yeah, sure.
I might disagree with you regarding this sprain. Because, see, the current guidelines, the NICE, they recommend X-rays. First, they don't recommend X-ray. And they're right now, they're jumping to the MRI. And there is what's called, when we elaborate the pain, secretus. So the duration, if it is more than 2 weeks, so this will indicate further scanning. It most likely doesn't need any investigation in the sprain, back sprain.
But you said they move to the MRI.
MRI after 2 weeks. After 2 weeks or 3, there are certain amount of days of weeks.
So you want to say that if it doesn't improve within 2 weeks, we can consider,
come back to us.
Yes, we can consider. Okay, this is a good point. I have to confirm it actually. This is time frame. Or this time frame, I need to confirm it.
Yeah, there is a time frame for that, and it's very easy from according to the guidelines. And sprain, because it's very common in general practice. This is back sprain.
Yeah, I know. I was working orthopedics, by the way. But the thing is that I was taking orthopedics residency. But the thing is that in our country we don't even consider doing MRI at all. I mean, at least for the first presentation. When the patient is having sometimes like maybe any neurological symptoms, or the patient is high likely, like very obese, or the chance of disc prolapse are high, definitely we refer to MRI. But here I need to confirm that. So thank you for pointing this out to me.
Because honestly, they are worried. Nowadays, the X-rays, the radiation are very massive in the back X-ray, so they don't recommend it right now these days. That's what I'm.
Okay, this is a good point. Thank you.
Because the GPs here, because most of the GPs here with me are all from UK.
But also mind some other thing. In UK, actually, they do not recommend MRI like in vain, like too frequently, just to save the cost.
Yeah, that's true. Indeed.
Yeah, that's what I believe. But just I need to confirm this about this time frame. I mean, if he
there is time frame. There is time frame. Yes.
Yeah. Okay. Okay, so this is a muscle sprain, guys. What if the person asks you, doctor, but I need to go back to work? You will provide him with a sick note. Sick note like medical certificate, like a reason for his absence from work. Okay, so next station is that disc prolapse, quite similar to it, exactly. What could be the difference between the disc prolapse and the muscle sprain, Dr. Zaid?
Yeah, disc prolapse and muscle strain. See, the muscle strain in the examination, there will be a limitation in the rotations. And when you do the rotation, the back examination and flexion and extension movement of the back, there will be limitations. And the disc prolapse, they are the same, but the disc prolapse, there is a radiating pain to the legs, to the lower legs, and there is positive red straight leg raising test.
Yeah, so this one word. This one word I need to hear from you. Straight leg raising test and
the radiation of the pain.
Yes, you mean, what do you mean by radiation of the pain?
Traveling, does the pain travel to
legs, right?
From the back, yeah, the lower legs, not to the thigh. Yeah.
Okay. So what about if there is any weakness in the lower limbs?
Yeah, there's also this one is also positive for it gives you a hint for further test. That's indication for MRI.
Okay. Yeah. What if there is a weakness? Can I say disc prolapse or coda equina?
Coda equina, if there is numbness, or sometimes there is one what's called numbness of the perianal numbness.
Perfect.
Or
Perfect.
The other ones, bowel
yes.
or bladder.
Bowel or bladder. Yes, exactly. So again, because many people are confused about that, disc prolapse can be back pain. It's exactly like back sprain, but the pain is referred to the lower limbs, especially the leg, and there is weakness there can be some neurological symptoms in the lower limbs, like weakness or numbness. This could be disc prolapse. But if I want to add a coda equina, which is a complication of this prolapse, coda equina, there are 3 specific things for coda equina. Number 1, loss of sensation, perianal loss of sensation. Do you have any loss of sensation around your back passage? Remember from the associated symptoms I used to ask the patient? Do you have any perianal loss of sensation? This is number 1. Number 2, do you have any bladder problem or bowel problem? Sometimes the bladder can be fully distended. Some other times he is going to wet himself. So they can be both. But just ask, do you have any bladder problem or bowel problem? Okay. So again, this prolapse can be presented with neurological symptoms. But the most important thing for coda equina, or the only presenting complaint for coda equina, is perianal loss of sensation and bladder and bowel problems. And here again, he is having history of lifting with heavy weights, or lifting of a history of any like any exercise, like he came from the gym or whatever. How to manage it? And again, in the examination, the straight leg raising test will be positive here, and the neurological examination can give you findings here by the examiner. Which investigations? Do not forget to mention the X-ray on the back, at least the initial. Okay, you are having condition we call disc prolapse. Sometimes it can be disc prolapse, sometimes it can be coda equina. The examiner can change it for you. Usually it comes as disc prolapse. What is disc prolapse, doctor? It is our backbone is supported by discs between the vertebrae. When this disc, the outer portion of this disc bulges outside, or sorry, when the inner portion of this disc bulges outside, this is what we call disc prolapse. Again, this disc is the supporting portion between each vertebrae to help them move freely. When the inner portion of this disc bulges through the outer portion, this is what we call disc prolapse. And this press on the nearby nerves. That's why you're having this neurological or this weakness. Why did I have it? Okay, simply, why did he have it? Because of lifting heavy weight. Besides some weakness or some already present weakness in the spine, some hereditary problems sometimes, or some transient family. Just generally due to some weakness, and it was worsened by lifting heavy weights. Right now, what are you going to do for me in the case of this prolapse? Okay, and what if he asks you about coda equina? This is what we call this prolapse. What if it's coda equina? Okay, in the coda equina, I will tell him it is again the same thing. It is a condition in which there is a pressure on the lower part or the lower collection of the nerves, which come from the lower part of the spinal cord. Again, pressure on the lower collection of the nerves, which come through the lower portion of the spine or the spinal cord. Why did it happen? Due to some pressure over them by the disc prolapse, due to the trauma or due to the heavy weight lifting. Okay, regarding the disc prolapse, what is the management of disc prolapse? Simply, number one, you are going to send the patient home, simply, but with some advices. We forgot to give safety netting and warning signs in the muscle sprain, by the way, on the back sprain. The safety netting or the warning signs for the back sprain are if you develop any weakness in your lower limbs, or if you develop any problem with your bowel or bladder, come back to us. So this is for the back sprain. Back sprain warning signs are the signs of this prolapse. This prolapse, I'm going to send him home with some few advice, which are, number one, some painkillers. Number two, some lifestyle, like try to be active, try to move from time to time, do not stay in the same position at the same time. Definitely like the muscle sprain. Some ice packs as well. What will be the warning signs? Warning signs will be the warning signs of the coda equina. Like if you develop any weakness in the lower, any loss of sensation in the, around the back passage, or any bladder and bowel problem, come back to us. Also, this patient, we may consider doing MRI to him, by the way. Why? Because he's having some neurological symptoms. So we can refer him to specialist after a while to perform MRI. Or we can refer him after a while to perform, your FY2 surgery. So here, we can refer him after a while to perform MRI. So again, you're going to perform MRI to him, but not necessary right now. We can consider it later. And we will send him home with some lifestyle advice, like activity and painkillers. Try to be more active. Try not to stay in the same position for a longer time. Try to change your posture from time to time. Try simple things like simple walking. Do not do any physical activity. Do not do any strenuous physical activity. Very important. Okay. Okay. What about the coda equina? In the coda equina, you will keep him in the hospital, and you will ask the senior to come and review him, and you will perform MRI right now. Why? Because this is an emergency. And definitely according to the result of the MRI, you may need to move him to the surgery, the decompression surgery, to relieve the pressure around the nerves. What are the complications? The complications can be some weakness, some prolonged weakness, some problems with the bowel, and some prolonged problems and some sexual problems as well. However, if this ever happens, we can help and support you. Remember, Code Equina is neurosurgery, neuro, like any neurological problem we talked about before. Okay. Those are the two stations of the back pain of the disc prolapse and Code Equina. They are coming as one scenario. Like sometimes they change it into Code Equina, and some other times they change it into disc prolapse. Okay. Now let's speak about last two ones for today. The last two ones for today are the back pain of the renal colic and the back pain of the prostate. I will postpone the abdominal aortic aneurysm till tomorrow. So, for the back pain in the renal colic, you know that actually the renal colic usually comes as loin pain, but sometimes it can come as back pain. Okay, if it comes as back pain, we know how to approach it. But usually like 99% of the cases are loin pain. So in the loin pain station, you will ask him, you will definitely elaborate the loin pain in a very detailed manner. And after that, what you're going to do, what are the associating symptoms to this loin pain? You know, you'll find this loin pain is coming as severe pain, severe radiating pain to the groin. It starts suddenly, sometimes it's rolling pain. We describe it as colicky pain or rolling pain. And he took some painkillers, but it didn't help. And he's feeling sick because of the intensity of the pain. Sometimes he can score the pain even as 9. So very severe pain. Fever with shivering is most probably, oh yes, you're telling the associating symptoms, okay. So the associating symptoms I'm going to ask the patient are nausea and vomiting, number 1. Number 2, any tummy pain. Number 3, any red flags are number 1, fever and shivering for the pyelonephritis. So the red flag are number 1, fever and shivering for the pyelonephritis. Number 2, any problem with the urine. Yes, he is having definitely some burning sensation in urine or some disturbed urine. So this guy is having urinary problem as well. So now he is having loin pain, which is due to this is the one who, I mean, this is how you can pick up that it is renal colic. Again, loin pain with some urinary difficulty. And after that, you're going to ask him about nausea, vomiting, fever, and shivering as well. Those are for the pyelonephritis. Okay, if he is male, now you can ask about any constipation, any bowel problem, any trauma. Okay, so what are your differentials here? Simply the differentials are number 1, pyelonephritis, which is a red flag. Very important here to be asked. The pyelonephritis. Number 2, the other differentials could be, what else? You can ask him simply about UTI, normal UTI, any smelly or cloud urine. Number 2, you can ask him about any GIT problem like any diarrhea or any constipation. By the way, from the loin pain, you know right now, sometimes it can be like iliac fossa pain as well. You know from the history that this is not appendicitis because the appendicitis is shifting pain. It started around the umbilicus and it shifted to the loin pain. So UTI, pyelonephritis, GIT problem. Those are the most important DDs. You can also ask him about any trauma. So 4 differentials here. Move to the past medical history. Very important here to pick up the medical conditions because some medical conditions can precipitate the renal colic. Like, do you have any renal problem? Have you had any previous episodes like this before? And for example, do you take any medications? Do you have any allergy? Any family history of similar problem? Move to the lifestyle, which is a core: smoking, diet, alcohol, physical activity. The four things can precipitate renal stones. Okay, now move to the examinations, similar examination to the back pain stations. Move to the investigations. Here, investigations are quite important because you will find in the urine dipstick that there are sometimes white blood cells, they can be some minute red blood cells. Minute, like maybe 1+ red blood cell or 2+, which means that definitely there is RBC in the urine due to the irritation by the stone. So now you can diagnose renal stone peacefully. So now simply you will tell the patient that your pain is because of we call renal stone. What is this? Stone is a collection of chemicals in your urinary tract, or some hard material due to collection and buildup of chemical substance in your urinary tract, most probably in your ureter. You know the ureter, by the way. Doctor, why did I get it? At this point, you will tell him that we need to do further investigations to find out the reason. Which investigations? Number one, some blood and urine test. Blood to see the minerals in the blood. Number two, urine test to see if you have any urinary tract infection. And also number three, we need to see if there's any bug in the urine by doing urine culture. Number four, we need also to perform some further investigations. Like what? Like maybe some CT scan. CT scan is the most diagnostic way of urinary stone, because this will determine or this will decide the mode of the treatment. Again, so many investigations, bloods and urine, and you can also add some thyroid function test and measure the uric acid level. You will do CT scan. Why CT scan on the urinary tract or CT-QB? Why? Because definitely it will be diagnostic to the renal stone, and not only this, it will determine the size of the renal stone. According to the size will be the management. If the stone is less than 4, this means that expectant management. If it is more than 4, this means that we need to do some procedure. If it is less than 4, I'm going to give him some advices. Sorry, if it's less than 4.5. 4.5, I'm going to give him some advices. Like what? Like number 1, drink much water. Number 2, smoking, alcohol, physical activity. I'm going to advise him about these things as well. So drink much water and these things. I'm going to ask him to reduce the tea and the caffeine and the coffee intake. Also, I'm going to ask him to abstain from some certain type of food, like salty food and fatty food. This is one thing, and we are going to give you some drugs. Which drugs? Okay, one mistake I made is that I advised him about the prolonged or the long-term management, but I should have addressed at least the acute case first. So for the acute or for the time being, before giving him some lifestyle advice, I need number 1 to keep him in the hospital. After doing the investigations, I need to keep him in the hospital. I need to give him some painkiller. Remember, number 1, admission. Number 2, senior review or not. No need to do senior review here. Number 3, you need to give him some painkillers for his pain. We're going to give him anti-sickness medication because he told you that he started feeling sick because of the pain. And number 4 as well, you can give him some medication which dilate the urinary tract. Temsol, to facilitate or ease the passage of the stone. Meanwhile, we have been performing these investigations, or we will be performing these investigations to find out the exact reason. After treating the acute case or the acute presentation, I need to give him some lifestyle advice. Which advice I'm going to give him? Number 1, like as I told you, diet, smoking, alcohol, physical activity, and try to be active. What if the stone is more than 4.5? If it's more than 4.5, I may need to do some procedure actually like the nephroscopy. PCNL, percutaneous nephrolithotomy. What is this? It is laser procedure in which I am going to pick or to fragment the stone. This is the station so far. Warning signs will be if you experience any shivering or fever, or if you experience any changes in your urine, come back to us, like the symptoms of the pyelonephritis or the UTI. Okay, this is enough for today. We're remaining with 2 stations for today. The 2 stations are the abdominal aortic aneurysm and back pain for the elder. We'll do them tomorrow, inshallah. Tomorrow will be, we will start earlier, 15 minutes earlier tomorrow, because we need to do these 2 stations, the remaining 2 stations, and after that we need to finish the remaining surgery stations. Surgery is long. We may need to discuss at least 19 stations tomorrow. So please, we need to start early, inshallah. And if we are left with 2 or 3 stations from tomorrow, it's fine. So anyone has got any question? Three? No three, doctor. And what's the problem being a housewife? I mean, they do more efforts than us, Masih. We have to respect that. Yeah, household chores.